Mr. President, acting president, we have a quorum.
Thank you very much. All right, good. I'm happy that we have a quorum. Let's get into some general announcements. These are going to be super important. So everybody that's online and here, please take special note. The date and location of the next MSB is going to be Friday, June 12th, also of the year 2026. It's going to begin at 9 o'clock. Fingers crossed. Virtually and in person at 303 East 17th Avenue on the 11th floor in the conference room, Denver, Colorado 80203. So if right now, if you are listening via audio stream and lose connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar and staff will chat out instructions. Please identify yourself when speaking. You have taken your comments because they are part of the public record. It is a responsibility of the Medical Service Board to adopt the rules that govern the department's programs through consideration of stakeholder input. This is in alignment with the department's mission and in the best interest of Coloradans. There is a testimony sign up for the open forum for each rule. If you need help finding the rule in which you're interested, please ask staff for help. Please keep your testimony related to the rule being discussed. Super important. Testimony on a rule or public comment will be capped at 35 minutes per rule and open forum. Sign up for testimony for a rule or public comment will end at the start of the Medical Service Board, which is now. Please, public comments will be limited to 2 minutes, and at the end of 2 minutes, your time will be up and we'll move to the next individual signed up to testify. With that, I think we should go to Adela for some departmental updates.
Okay, thank you. Can everybody hear me okay?
Yep.
Great. Good morning, everyone. This is Adela Flores Brennan, Medicaid Director at Healthcare Policy and Financing. I want to start with thank yous. So thank you to our hosts here at the Department of Human Services and to the lovely folks who gave us a tour yesterday of child welfare. That was a very educational experience. And then also to David Pump and staff at Pueblo Diversified Industries for the time that they took to guide us through a tour and hear about the special work that you all are doing. I also want to thank the board. I know that we have had long hours with these board meetings, and I appreciate your commitment and sticking to the long time that is beyond the agenda. We've had a lot of questions. You have been carefully reviewing your documents and coming prepared, and we really appreciate that. And know that we're here because we share a common interest in supporting our members and the longevity, sustainability of the Medicaid program. I do want to just recognize that this is, we're in a hard, scary, complex time right now with the budget reductions that are on our plates. And I want to be mindful that we recognize that there are people who care very deeply about these issues, both internally at HCPF, the board, and our stakeholders. And we're grateful for the participation and engagement that is helping us to develop these rules and develop ideas for the future. We want to just provide a reminder that we would like to keep this in a very constructive space. So asking that people be tough on the problem or tough on the issues, but not the people. We are seeing, because of the passion behind all of this, we are seeing staff being targeted and trolled online. There have been intimidating comments made. And so we just want to try and bring the temperature down a little bit. And if we need to, during the course of our hearing today, we will try and call a timeout or reinforce that we need to make sure that we're addressing the issues and not coming after staff of the department. So with that, I will get into some updates. The budget is the big thing this year. We expect that the long bill, which is the budget bill, will be signed later today by the governor. Between 2025 and 26-27, the governor has issued executive orders to reduce our spending, and the legislature approved $297 million in cuts. Next fiscal year, the long bill includes additional reductions to Medicaid in the amount of $941 million in total funds. That's $359 million in general fund. These reductions have mostly come from provider rate cuts, including a 2% across the board cut and caps on certain services. So we recognize that this is going to impact very significantly our providers and our members. The early estimates as of right now are that this is not the end. We will have additional cuts that we need to make for the next fiscal year. So I just want to put that on folks' radars. And we will need to do additional rulemaking to both comply with the long bill, the budget, and the so-called orbital bills, the bills that came along with the budget that had to change statute in order to effectuate some of those cuts. This legislative session ends next week. So we still have bills that are running through at a really rapid pace right now. Ones that we are tracking are ABA licensure. There's a bill to license ABA facilities and providers. We have a big bill right now having to do with county administration and eligibility. There is, oh, that one died yesterday, so I won't mention it. There is a bill on non-emergency medical transportation that we are watching closely. And then a bill that was just recently introduced that establishes a bipartisan 10-member legislative commission to examine Medicaid spending. And so that we expect to go into effect this summer. It will host about 6 to 12 meetings, and there is funding for the legislature to convene. That funding does not come to the department. So we should probably expect rulemaking to come out of some of these as well. NEMT, this is a big transition. Non-emergency medical transportation, we have a new broker who has been contracted after multiple RFPs, and that new broker is MediDrive. We are going live with our transition on July 1st, 2026 in the 9 county metro area. And then there will be a phased approach to implementing the rest of the state so that we can be mindful that things are, going well before we flip the switch. On the federal side of things, the team is working really hard to implement all of the provisions of HR 1. The first eligibility impacts will be to qualified immigrants. We expect 7,000 members to lose coverage in October. Those are folks that are lawfully present, asylees and refugees. And the federal law is just changing who is considered qualified for purposes of Medicaid. We are going to be starting outreach on that soon so that people can be prepared and get doctor's appointments and things like that taken care of in advance. And then we are also just wanting to acknowledge that there's a lot of federal attention right now on fraud, waste, and abuse. We have a lot of inquiries coming in that are pretty high profile. Congress has been sending us questions. We're responding to those. And then recently CMS has reached out to the departments in all states, asking us to revalidate all of our providers in 2 years and to revalidate all high-risk providers in 12 months. So more to come on that. We are having to put together a plan, and that is due in June. So with that, I will stop. Great news.
Thank you very much. In the expedience of time, we're gonna move straight forward into the approval of minutes from October 10. Do I have a motion for that?
It's James McLaughlin. I'll make a motion that we approve the minutes as written.
Thank you. Do we have a
Morgan
second?
Honey, Morgan Honey, second.
Thank you, Mr. Honey. All in favor?
Aye.
Any opposed?
Aye.
Abstaining, motion passes. Thank you. We've had a lot of discussion, and the state is asking to move the next document 1 from consent into final adoption. Can I have do I need a motion for that, or do we just do it?
Make a motion.
Okay, can I have a motion to do that?
This is Morgan. I'll move to move document 1 from consent to final adoption.
Thank you. A second.
Tina, second.
Thank you, Dr. Mulkey. All in favor?
Aye.
Aye.
Any opposed? Abstaining, motion passes. And interestingly enough, Cassandra, who is online, we go right into that as our first document under final adoption. Cassandra, you there?
I am. Can you hear me okay?
I can hear you wonderfully. If you'd be so kind as to get us started on this process.
Absolutely. Thank you, Mr. President, members of the board. My name is Cassandra Keller, and I'm our Community Options Benefits Section Manager. That means my teams oversee our home and community-based services, as well as a couple of state plan benefits, including long-term home health and private duty nursing. I'm here today to bring back in front of you the regulations pertaining to the post-eligibility treatment of income. If we can go to the next slide, please. As you have just done, thank you. You have taken the rule off of consent. After that initial reading, there were requests from stakeholders to add some further information and clarification to certain points. In response to that and those requests, we made those suggested edits to the regulations. And because of those changes, we requested of you to remove the rule from the consent agenda for a final presentation. And I will go over what those changes are in a few slides, but we just wanted to make sure for transparency's sake that those changes that we were making were presented to everyone and had stakeholder feedback and engagement on that. Next slide, please. So I won't go into great detail again about what PETI is, but just as a quick refresher, post-eligibility treatment of income is already used across many of our residential Medicaid programs in Colorado. This includes nursing facilities, assisted living, supported living programs, and other HCBS waivers. These are community-based residential settings where people live and receive support. They're not institutional settings. In these programs, members keep money for their basic needs first. Only income remaining after those protections may go toward the cost of care. So this is that cost-sharing mechanism where members, after those protected amounts, help pay for the cost of their services. This approach is applied consistently across these programs. Next slide, please. So what is different for the DD waiver? Well, mainly our developmental disabilities waiver does not have PETI applied today. It did back in prior to 2009, but since then it is no longer, it has not been applied to this population. That means Medicaid is covering the full cost of residential services for members on the DD waiver. In other residential programs, members contribute a portion of their income. But this, again, only happens after basic needs are protected. This includes income like Social Security or retirement benefits. So we have similar residential services being treated differently. The DD waiver is the only residential model that does not follow this approach, and this results in inconsistent treatment across similar residential programs. Next slide, please. So the questions and concerns that we heard, there was three main areas. Fiscal impact. There needed to be more information about affordability and daily expenses. Independence, maintaining housing and continuing to work, and then better understanding of PETI, how income is counted, institutional settings, and family income. Next slide. So based on the feedback, we have made several targeted updates. One, we expanded employment protections with clear definitions and verification. So making it very clear about what type of employment is included as an exception and what verification would be required. We strengthened household expense protections for member paid costs. So really looking at those expenses for household costs for those who live in their own housing. We clarified housing deduction. This only applies when the member is directly and individually responsible for the housing costs. We've reinforced financial protections. All required federal deductions are included. We clarified treatment of trust and ABLE account distributions in alignment with federal Medicaid requirements, including when distributions are excluded, meaning qualified disability expenses, or counted as income based on how funds are used. We clarified members with limited income may have little or no contribution. And really just bottom line is these changes are about equity. Members receiving similar residential services should be treated consistently across waivers. Next slide, please. Just want to make sure, like, very clear, this proposal has been approved through the JBC process. You all approved the initial draft of these rules. The process is moving forward with our federal partners for the Centers for Medicaid and Medicaid Services. We're in the process of getting that final approval. We anticipate implementation of July 1st upon the approval of these rules. And ultimately, we're really trying to ensure individuals receiving similar residential services are treated consistently while maintaining protections that support independence and community living. Thank you.
Thank you, Cassandra. I appreciate your process or your discussion. I just have two quick questions before we will open to the board. One, if you can go back on your presentation, 3 slides. That one right there. Wait, go back another one, sorry. There we go. So understanding petty, the very last bullet, questions about trust, ABLE accounts, and housing deductions. Can you spend a little bit of time just discussing the now bringing in ABLE, which is a big deal in the community?
Yeah, absolutely. Thank you, Mr. President. This is Cassandra Keller. So trust income, there's so many different varieties of trust, and we don't want to be very explicit about trust information within the rules, rather having that more in guidance. But specifically with trusts, special needs and ABLE trust, we're not counting that income on the front end. So when someone is putting income into their trust, that's not counted as part of the post-eligibility treatment of income. What federal guidance allows us to do is that if you're taking a disbursement from that ABLE or special needs account, we can count that income toward the petty if those expenses are for non-qualifying disability expenses. So we're just trying to make it consistent with federal law about and federal requirements of when we can and cannot use those funds. So we're not counting the income that are getting put into the ABLE account, but we are counting that income on a disbursement when they're not for qualifying expenses.
Thank you.
We put that in rule, Mr. Pompa, we put that in rule because there were so many questions about ABLE accounts and how this was working. And so we really wanted to call that one out explicitly so that it was clear how that was to be used.
Thank you. This is David. For the go to the order, the ABLE accounts are trust specifically for adults with disabilities, and it keeps that money out of resource when determining program or determining benefits. And in Colorado, it's national, but in Colorado, it's been very strong and a great tool, very important to the community. Second, Cassandra, my second question here real quick is recognizing that this discussion is fairly hot. I was curious what other states use this best practice for petty with the DD waiver specifically.
What other states apply petty to folks with intellectual and developmental disabilities?
Yeah, sure. On the DD waiver, like for this rule, what are like other states do this as well? This is best practice.
Yeah, I mean, thank you for the question. This is Cassandra. It's interestingly like Colorado divvies up how petty is applied, but generally, you use petty as a cost sharing mechanism to help with that burden of cost. And so it's pretty standard across these programs and standard across the country that and other Medicaid programs that when you're utilizing these residential benefits. And in fact, it doesn't even need to be just in members receiving residential services. They also apply petty to individuals who live in their own homes and receive services. So it's just a really helpful way that states have to be able to, with that cost sharing, to take the burden off of the state. And so Colorado isn't by no means unique in applying petty to the various disabilities and populations in their states.
Thank you, Cassandra. Board members, do we have any questions? By the way, here's a disclaimer, for our board members who are online. It's going to be super difficult for me to find you if you're raising your hand. So I'll just ask that you jump right on and just exclaim that you have something going on so we can move to you. But I'm not hearing anything. For with that, I'm going to ask Mr. Sykes if we have public testimony.
This is Chris Sykes. We do have public testimony. Do we have a Nicole Bias in the room? We have Nicole.
Point of order, how should we do that?
You want me to move this table?
Yeah, if you don't mind. I'm sorry, I don't mean to displace you, Adam, but yeah.
We actually do mean to
Yes,
display.
exactly. Wish I had foreseen this, but hold on, let me get a microphone just a little bit closer. We'll put one right here. You don't need to apologize. There you go.
And I'm so grateful when somebody's in the room, you do not need to ask, can you hear me? Because we can't. I recognize that. 2 minutes. We have that on the books.
Thank you, Mr. Chair. My name is Nicole Villas. I'm here advocating for adults with intellectual and developmental disabilities. There are so many problems with this rule as written. I'm sure you got a lot of that in the testimony yesterday. So aside from the fact that it attacks the most vulnerable, most voiceless, least able to help themselves in the entire state, and that's a problem in and of itself, I will get to the half-truths that you have been told that have probably influenced your decision. The only reason we're at this point in the petty process is because the JBC didn't get all the information they needed, and you haven't gotten all the information you needed up until yesterday when you got those 28 testimonies. In those half-truths are that there's equity across waivers. The other waivers where petty is applied, people do not live in their own homes. They do not live in family members' homes. They are in licensed facilities. They are in the community. Pickbuff is right on that, but they have separate licenses. These are not family homes. These are not host homes. These are not sibling homes that they're living in. Another half-truth you've been told is that their living costs are covered and excluded when they are legally responsible for the home. No member on the DD waiver who functions at a 3-year-old level is going to be legally responsible for their home. For example, my son, when he goes to live, hopefully, with his siblings after I die, he will not be legally responsible for that home. It doesn't mean it costs less for him to live there. He still needs to pay an equitable amount, but that would not be excluded from petty under the current rules. So asking people who have guardians and can't wipe their own bottoms, they can't make decisions to be legally responsible for the home is inappropriate. Another half-truth, it was applied to the DD waiver before people were allowed to live in their own homes. So when people lived in institution-like settings, that's when it was applied to petty. It was removed because it was unmanageable. It was impossible to calculate, and the case managers were overwhelmed because they're now supposed to be accountants, specialists on special needs trusts, and they're supposed to keep track of all of this, and they have no training. More regulations are necessary. This rule is not ready for adoption. It needs a lot more work. And there were other options available. We could have doubled the premium for the working disabilities.
Thank you. I appreciate you here. Do we have, I think our now process is that we just go to the next one at the end, department response. Thank you very much. I appreciate you being here. Who do we have next?
This is Chris Sykes. We have Hannah Rayleigh.
Not in the room.
Chris, this is Kelly. I don't see Hannah online anymore.
Oh, she's there. I apologize. I just searched. I'm going to press allow to talk. Honey, are you there? just need to unmute your phone.
Hello, can you hear me?
Yes, we certainly can.
Oh, fabulous. Thank you. I apologize. There's a lot of buttons popping up. Thank you so much. My name is Hani Rayleigh. I'm the executive director of the Arc of Aurora. I too am asking the board to reconsider the proposed petty rules for people with IDD receiving DD waiver and residential services. I've already written to you describing many concerns around this rule being comparable to institutional care settings, assuming all folks with IDD can work if they choose to. And hopefully you've seen that applying discriminatory rules for those who are unable or have access barriers is just morally and functionally flawed. Petty might make more policy sense in systems designed for individuals who acquire disabilities later in life, for those who have had opportunities to build wealth, purchase homes, establish careers, support spouses, and accumulate assets. That is not true for the large majority of people with IDD. Colorado has spent decades intentionally moving away from institutionalist and ableist models, but this proposal risks such progress. In fact, petty has been applied to the DD waiver decades ago, and even then it was ripe for errors, abuse, and it was not considered a savings to the state, even in a system that felt more coordinated and caring. We ask, what has changed in the last 16 years that makes this viable and manageable now? I would argue that the system is more fractured and incapable of managing such a system. People with IDD are already paying for their room, board, personal needs. Their disability-related services are already included within the DD daily rate. Medicaid also recovers costs through a state recovery after death. So it's fair to ask, why is it necessary to impoverish people along the way? We need more clarity around the special needs trust and ABLE accounts. The current rule does not provide any additional clarity. It's vague and could unintentionally disincentivize savings and financial planning for people with disabilities. Dollars placed into these accounts treated as income, or there's an assumption on the residential or service provider side that we'll understand what the Medicaid allowable rates are. We're deeply concerned and ask for you to pause and reconsider.
Thank you very much for coming and having your words. We appreciate that very much. Mr. Sykes.
This is Chris Sykes. Do we have a Deanna Cairo in the room? Please come forward. Thank you.
Administrative point. I didn't see my testimony posted online, and I did send it to you yesterday at 1. So I printed copies out.
Okay.
Can I hand them to somebody and they distribute them, or should I just hand them out? Thank you.
Thank you for bringing a copy. I appreciate that.
Thank you.
All right. Thank you for being here with us today. Please recognize 2 minutes. I don't want to be rude when I say, stop. Thank you very much.
Understood.
Go ahead and start.
Thank you. My name is Dina Cairo. I'm the president of COAID. We are an organization that advocate for adults with disabilities in Colorado. I just want to address a few things about the final adoption process today. The rule that you received for consideration today is a very dramatically different rule than the prior consideration. And so we don't think that final adoption is appropriate. There's a lot to review on this rule, and this hasn't actually been available. This version of the rule has not been available for public notice and comment as required by CMS regulations for 30 days. And so I just want to discuss some of the key differences in the rule that are really leading to some significant problems. As my colleague mentioned, people who live in their own homes will now be subjected to this rule, whether that home is placed in trust for them, whether that home is rented for them by a loved one, whether they live with a family member in their own home. And that is going to create a situation that threatens to disrupt housing for people in the IDD community. For those who aren't familiar with the DD waiver, we have a significant housing problem for people on the DD waiver in the IDD population. We are overly reliant on host homes, and many of us don't find that to be a good solution. Many people with DD don't want to live in host homes because they don't like the idea that they will become homeless if the situation doesn't work out, or the host home provider decides to do something different. And so many of us are trying to craft a solution for our loved ones where they will live in a home that is rented or purchased for them in an intentional living community, and that they will have staff come in and take care of them. This rule upends all of that. It's going to become almost impossible now for people to plan for the future and for people to execute on that kind of a strategy if all of their DAC, basically their disabled adult child income, which is the primary source of income for people after parents die or retire, is basically withheld except for a few meager $100 a month to buy, shoes, or maybe even have to forego buying things like winter coats. So that is a significant problem.
Thank you for your time up here. I really appreciate that. Mr. Sykes, we have more public testimony.
This is Chris Sykes. We have Betty Lehman.
This is Betty Lehman. Can you hear me?
Hello, Betty. This is David. I'm happy to hear you, and you have your 2 minutes. Please start.
Thank you. This rule will confiscate something called SSDI, or as just referred to as disabled adult child. SSDI is not the same as SSI. SSDI is Social Security Disability Insurance. It's insurance that families pay in through their work earnings so that if a family member becomes disabled, they can pull on that insurance. It's not an entitlement, it's insurance. It's a family-generated resource for the person. The other confiscation will be court-ordered child support. Child support is considered income by Medicaid, not for support of the child as it is by the courts. And so they will be confiscating everybody's child support. This means that judges will no longer order child support for people in long-term care because they anticipate that Medicaid's going to confiscate it. So this is an artificial poverty. The petty limit is $11,928 a year, but federal poverty level is $15,650. That's $4,000 a year higher for federal poverty level. So you're artificially impoverishing people by taking their SSDI and their child support, which is immoral, unconscionable, and this needs to be remedied. And when the state says that they're going to have a housing expense, it's not based on actual expenses. And I hope you all realize that nobody can in America can live on $810 a month. No one, and including people who cannot work. And so this is very discriminatory against people who cannot work because their IQ is too low. And it does interrupt with all kind of future planning. How can anybody plan for a loved one that has this level of disability?
Time is up, Betty. Thank you very much for spending some time with us today. I very much appreciate your comments. Mr. Sykes, do we have additional public testimony?
This is Chris Sykes. We do. We have Kathy Fiber. I apologize now. I probably mispronounced your name.
It's Kathy Fiber, but thank you.
Thank
Hi,
you,
sorry.
Please go ahead and begin your 2 minutes. We really appreciate you being here.
Hello, I'm a mom of a 26-year-old son in Littleton, Colorado. And I just want to talk, the provision regarding treatment of trusts and able accounts are hopelessly confusing and will be impossible for case managers and PASAs to apply correctly. Importantly, the current rule, which has been in effect for many years, says nothing about trusts or in the petty calculations. There is no reason to include a provision regarding trusts now. It creates a level of complexity for calculating petty that essentially requires case managers to have legal training in trusts. In addition, including these in petty creates ambiguity regarding clawback after death under existing federal regulations and is in conflict with the state laws, where Colorado expressly removed estate recovery for able accounts several years ago. Trust provisions were not needed in the rule before, and they are not needed now. The majority of trust and able account distributions are not income to the member in any event. So this is unduly burdensome and unnecessary addition to the rule. The provisions regarding income from employment were also narrow to only include 1, members on the buy-in, and 2, members with income from supported employment. In the prior version passed in April, all income from work was to be excluded. There is also a requirement now that employment be ongoing, which is hopelessly vague and unnecessary. Some individuals, due to their disability, have difficulty maintaining ongoing employment or perform seasonal work. All income from work should be excluded from calculation. The entire basis of the department's estimated savings is based on petty contributions on the BI waiver. The BI population is completely different than the IDD population. Members on the BI waiver, unless they sustain their injury at a young age, have a work history, and many more of them qualify for SSDI based upon their own work record. The DD population will generally only qualify.
Okay.
I'm just going to say this is totally unfair. If we're looking at fairness, this is unfair.
That, thank you. I don't mean to be rude, and I'm sorry that I have to cut you off. Mr. Sykes, do we have additional public testimony?
This is Chris Sykes. We do. We have Pat Chamberlain.
Wonderful. Pat Chamberlain? Oh, there we go. Hi, Pat. This is David. Please, thank you for being here. Please start your 2 minutes.
Our family strongly opposes the newest iteration of continually changing proposed rules regarding petty. PICPUF has created a false narrative that suggests that petty is applied to all other waivers and that applying petty to the DD waiver would be equitable. Petty has been a income of should be in an instant setting.
Sorry to interrupt you, Pat. I'm sorry to interrupt you. It sounds as if your volume is on your system because we're getting a lot of feedback. It's difficult to hear the important things we need to hear from you. Can you try to pause?
So there's, Pat, this is Chris Sykes. I'm in the Zoom meeting right now, and I see that you have 2 entries. I see the one where the microphone is active. Could you possibly turn off the microphone and sound on your secondary device? Could you mute it?
Oh, that's perfect.
Because I think that will help, because your testimony over the Zoom call is just getting an echo and becoming convoluted.
Going to try that.
Would it be okay if I remove the secondary?
Yes, please.
Okay, let's do that. And okay. No, I don't need to report. Okay. Can you still speak, Pat? Because I removed the other Pat Chamberlain.
Is that any better?
Oh my gosh, thank you, Pat. I really appreciate that. You have
is that any better?
Yes, do you
Hello?
hear us? Oh no.
Not to interrupt, sorry.
Hello? Hello, hello?
She has to separately connect them, and
Hello?
that's why. Now she can't hear us. Now she can't hear us. Okay, yeah.
Okay.
I'm gonna.
Thank you.
Hear me now?
Very helpful.
Can you text her and let her know that we hear her and we'd love to hear her testimony?
Sure. That's perfect. See yours. I told you. Yeah.
I just chatted to Pat that we can hear you.
So you can just go ahead with your testimony.
Apologies.
Your hearing aid situation.
Makes sense.
Well, let's restart.
I just texted her.
Thank you for that.
I recognize Pat can't hear me, but I'm begging her to start. All of our friends texting and telling. All right, let's come back to Pat when that gets sorted out.
Okay.
Oh wait, I just heard her.
Is that better sound for you?
Yes.
Yes.
Thank you so much. I appreciate it. I'll start now. Our family strongly opposes the newest iteration of the continually changing proposed rules regarding petty. PICPUF has created a false narrative that suggests that Petty is applied to all other waivers, and applying Petty to the DD waiver would be more equitable. In fact, Petty has only been applied to income of waiver members who require care in institutionalized setting. DD waiver members who require institutionalized care reside in one of the regional centers, and Petty is applied. As it is with all other waivers, when DD waiver members live in their homes and community, Petty is not and should not be applied. Any projected budget savings should be recalculated now that approximately 25% of DD waiver members who work will be exempt from Petty. Before these proposed rules, a member could keep up to 3 times SSI, or about $3,000 a month. These rules cut that amount by 60%. These rules take the most income from DD members who are unable to work. Aging parents who have worked and earned Social Security are relying on SSDI to meet the needs of their son or daughter when they retire and after they die. Petty would take any income, including any SSDI income, over $1,245 a month. These rules discriminate against members who have seasonal jobs. These rules require a member with IDD to keep receipts, bills, pay stubs, income distribution records, if any, and other paperwork. Most members on the DD waiver require extensive support in all financial areas and are not capable of sitting down with their case manager monthly to fill out a Petty form. DD waiver members live in a variety of settings. Who will keep track of where members live, what the expenses are in each setting, and how much the member pays for costs? Applying to the Petty to the DD waiver is morally wrong, creates inequity, discriminates against the most disabled members in the state, forever keeps people with IDD in poverty, and most of all, denies people with IDD any hope that they will be able to live independently in their own community. We urge the MSB to deny the application of Petty to the DD waiver.
Thank you, Pat, for being here and for working through that issue. Your words are very important to all of us. Thank you very much. Mr. Sykes, do we have more public testimony?
This is Chris Sykes. We do. We have Robin Vint.
Can you hear me?
Thank you, Robin, for being here. I would love to hear what you have to say. Your 2 minutes starts now.
Thank you very much for listening to me. I am also in opposition of Petty. I have a 24-year-old daughter on the DD waiver who will never work, who has functioning level of around a 3 to 4-year-old, so a toddler level. She needs somebody with her 24/7. She cannot ever be left alone. A host home is not the appropriate placement for her. And as many other parents have stated, it's very difficult to try to figure out how to support a 3-year-old for potentially the next 40 to 50 years. I've talked to many, many other parents, and people are resorting to purchasing homes and staffing it with caregivers for their child, because there are not a lot of other options in the state of Colorado outside of the regional center or a host home, which are not appropriate for our children. This is very, very, very expensive. We are sacrificing our retirement, vacations, all of our discretionary income to try to figure out how to make this work for our child. It is very, very cruel and heartless to now take away the limited resources that we have put together to try to take care of our children. This includes our disability income. When we retire or die, they're garnishing it. They're garnishing any housing voucher income or the benefits of any housing vouchers that we apply for on a federal level. Every source of income is being taken away. All of our planning tools are being a state of planning tools are being taken away. This is very, very depressing and sad for all parents and adults with IDD on the DD waiver.
Thank you, Robin, for your testimony. It certainly means a lot, and I appreciate it. Mr. Sykes, we have more public testimony, I understand.
This is Chris Sykes. We do. Do we have a Michelle Dumais in the room?
We do.
Fantastic. Michelle, I am so grateful that you're here to speak with us today. You've already heard you have 2 minutes. I don't want to be rude when it's up, so I'd say please. Thank you very much. Please go ahead and tell us what's on your mind.
I oppose the petty rule as written, not as a commissioner for the Denver Commission for People with Disabilities, nor as the co-chair for the Ideas Council that advises about mill levy spends. I'm a member of COAID. I'm also the guardian of an adult community member with IDD. This rule creates legal risk, harms members, destabilizes community living, and pushes costs onto families, providers, courts, the case management agencies, passes, and ultimately the Medicaid system itself. I have 5 main concerns. One is the legal risk. HCPUF's new interpretation penalizes members who cannot legally sign leases, mortgages, or housing documents because of disability or guardianship. Denying home expenses deductions on that basis may create discriminatory impact and expose HCPUF to legal jeopardy. Number 2, it harms members. Easy to understand. Petty will reduce income needed for food, clothing, transportation, utilities, hygiene, repairs, replacement items, and community participation. These are the basic social determinants of health. And taking this income will make members poorer, less stable, and less safe. Number 3, it's definitely a risk of institutionalization. Host homes, family homes, shared living arrangements are not assisted living facilities. They are community homes. If petty destabilizes these fragile arrangements, members may lose housing, family support, and community placement, increasing the risk of crisis, homelessness, hospitalization, and institutionalization. Number 4, the burdens become shifted everywhere. CMAs and PASAs may be forced to act as accountants, lawyers, benefits experts, trust advisors, able account interpreters, and financial monitors. Families and guardians will be left with the fighting impossible calculations. Judges may see more guardianship, housing benefits, and exploitation disputes. And finally, the 5th one, there's no real accountability in what is written there.
Thank you for bringing most of 5. I appreciate
That was
what you have to say.
Made it.
Yeah, most of 5. Like I felt like there was more. That was really important. Thank you very much. Appreciate that. Mr. Sykes.
This is Chris Sykes. We have Bryce Rafferty.
Fantastic. Bryce, are you there?
Yes, I am. Can you hear me?
Yes, sir, we certainly can. You have 2 minutes. Go ahead and start.
Good morning, Chair and members of the board. My name is Bryce Rafferty here on behalf of the Colorado Cross Disability Coalition in conditional support of this rule. While we wish that we could get rid of petty for everyone, we understand that petty is in federal regulations and our General Assembly has also required that this be collected. But if petty is going to be used, it should be equitably applied. Our request today is to make sure that the rule is clear enough to avoid unintended harm during implementation. We recognize that the department has already taken some of the following into account, but wish to identify them as critical areas for rule improvement on implementation and for the record. First, the rule mentions special needs trusts, able accounts, but it does not clearly explain which distributions count as income for petty. Before implementation, HCPUF should provide plain language guidance, public-facing worksheets, and specific examples. Second, HCPUF should distinguish between unrestricted cash paid directly to a member and protected able or trust funds used for direct vendor payments and qualified disability expenses. All affected parties need clear instructions so lawful able or trust planning is not disincentivized by confusion. Third, HCPUF should clarify how petty treats real-world housing arrangements. This should also be a role for members to pay their genuine share of the lease or mortgage when they have full access to the home, not just to a rented room. Finally, HCPUF should clarify the employment exemption for people who work but are not enrolled in the Medicaid buy-in. Is all income exempt from petty or only earnings from employment? This distinction is important for members deciding whether working is viable. So CCDC supports equitable implementation, but equitable implementation requires clear rules, clear examples, and consistent case manager training before members are assessed. Thank you.
Thank you, Mr. Rafferty. I appreciate that. I believe that we do not have any more public testimony, Mr. Sykes.
This is Chris Sykes. That is the end of public testimony for document 1.
Thank you. At this time, does the department have responses to what we heard in public testimony?
Yes, please. This is Cassandra Keller.
Please, go ahead.
Thank you. First, I'd like to acknowledge that it is understood that this is a difficult change for families. This is going to be a big shift for how families are operating and figuring out solutions for how their adult children are living in different situations. Unfortunately, HCPF has been tasked with making hard decisions in the face of this budget crisis. We were asked by stakeholders to specifically address trust income, housing expenses, and employment. We are responsive to those stakeholder requests by making those rule revisions that are before you today. We cannot justify treating different disabilities differently. We've made these rules nuanced to fit these members and their nuanced needs, specifically calling out things like ABLE accounts because that is far more prevalent among the IDD population. I want to reiterate that PETI applies to folks with various sources of income. We're looking at SSI, SSDI, trust, other different sources for those individuals on the EBD, CMHS, and brain injury waivers. These members do not reside in institutional settings, and they live in the community, receiving these public benefits just like members on the DD waiver. Pat's not wrong that our savings have actually changed since this budget idea was first put forth, but that was in order to protect this population. We exempted those who work, both in buy-in and those who are employment services or just working outside of a benefit. We're protecting allowable ABLE distributions, and we're protecting those who are responsible for their own housing expenses. So our savings have been reduced because we're trying to make sure that this population is able to live a life where they're able to work, where they're able to live independently. I want to thank Bryce for his support today of these rules. We agree the additional guidance and guidance is needed along the way along with ongoing clear training for case managers. But this is not a new job for case managers. They have been doing this all along the way over the past many, many years. We're providing training on how this applies to the DD waiver, and we'll make sure we provide that nuanced information about how these various calculations are made. So again, this is about equity, making sure members across our various residential benefits are treated equally and have the same protections and the same contribution to their cost of services.
Thank you, Cassandra. I appreciate that feedback. I think that would end the public testimony. We may have no more any board questions that came up during that process. Thinking, hearing none, I will, I guess, entertain a motion.
It's James McLaughlin, I'll make the motion. I move the final adoption of document 01 MSB 251022-B revision to the medical assistance rule concerning the post eligibility treatment of income section 8.702.BB, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Point of clarifications 8.7202. Can you accept that amendment?
I do.
Thank you. Do we have a second?
This is Morgan. I'll second.
Okay. All in favor?
Aye.
Aye.
Aye. This is Morgan.
Opposed? Nay. Abstain? I'm hearing 5 is the number, and that's what we needed to pass. Just clarifying.
This is Chris Sykes. Yes, we have 8 board members with us, and 5 is a majority of the quorum.
All right. With an exceedingly heavy heart, that passes. Thank you. Let's document 2. Russ Ziegler, I'm assuming that you're on light?
I am. This is Russ. Can everyone hear me?
Certainly can. Let's talk about document 2.
Wonderful. Thank you. Well, just as by way of introduction, good morning, Mr. President and board members. My name is Russ Ziegler, and I'm a compliance and policy advisor in the administrative law and policy section of the department. I'm here to present the appeals process rule, MSB number 25-09-17-B. Rachel Entrekin, the department's legal division director, Christine Nirnez, a department appeals officer, and Kelsey Leva, the department stakeholder specialist who worked on our outreach for this rule, are also available to answer questions following my presentation, which I'll jump right into now. Next slide, please. Okay, so these are the individuals that I just referenced. Next slide, please. So I won't go into great detail with this because we did a deeper dive at the initial reading, but I just wanted to provide this visual representation of the appeals process and what it looks like. So it starts with filing an appeal. The applicant member has 60 days from the date of the notice of action letter to file the appeal with the Office of Administrative Courts. Then the Office of Administrative Courts has a hearing and issues an initial decision. After the initial decision, there's an opportunity for the parties to request or send in exceptions, essentially showing disagreement with the initial decision. Now there is a change under the proposed rule in that for that process. We've added more time for parties to send in exceptions, and also if there's been a request for transcripts, we give an automatic 45 additional days. Now the final agency decision, that is changing also under this rule. So under the current process, every initial decision will get a full substantive review by the department. Under the proposed rule, not all, but everyone will receive an administrative review. But I'll go into more detail in that later in the presentation. And then finally, there's one more bite at the apple after the final agency decision is issued. This is a motion for reconsideration. And in response to stakeholder comments, we have clarified that motion under the proposed rule. Next slide, please. So we wanted to give an infographic, really putting into black and white what this new process will look like. So please note that this would be the new process under the proposed rule if it is adopted, not the current process. So what does that look like? So an initial decision is issued by the Office of Administrative Courts. So the first question would be, did someone send in an exception or request more time to send in exceptions or request a transcript? So basically, did anyone disagree with the decision? If that answer is yes, then there will still be a full substantive review of that initial decision. The department's Office of Appeals will issue a final agency decision. Now, please note that judicial review is allowed if an exception to the initial decision was requested or the final agency decision is different from the initial decision, and that's by statute. Okay, track 2. So let's say that no one disagreed with the initial decision. So the initial decision was issued, no one disagreed with it. Under the new process, so you'll see at the top of the infographic. So the answer is no. But the initial decision will still receive an administrative review. So this is a more limited check. And if you want to get more detail on exactly what that looks like, if you could look at your rule package. So this is the new section 8.057.9.g. So that administrative review looks like this. The Office of Appeals shall complete data on outcomes and conduct an administrative review of all initial decisions to ensure they include findings of fact, conclusions of law, and an order granting or denying relief. Now, we got feedback from stakeholders stating that we should have at least a limited legal review. And we thought that was actually a good idea. So I requested during the initial decision, the initial reading, that we add this subsection in the one subsection 1 underneath that, which is in highlight in your rule package, that does specifically state that the administrative review includes reviewing the initial decision for the proper application of federal and state law, regulations, and policies. We appreciate stakeholders for giving us that feedback, and we wanted to respond to that. Next slide, please. Oh, I'm sorry. Could you go back to that slide? I wasn't quite done with that. Sorry. So we're at the administrative review process. So that's where no exceptions have been sent in. No disagreement was indicated by the parties. So the department will still do an administrative review, that limited check. And the department can elect to still do a full substantive review of that initial decision and issue a separate final agency decision. In that case, the department must send a separate notice notifying the parties that, hey, you didn't provide any disagreement. However, we've looked at it and we still want to do a substantive review. Now, if the department does not elect to do that, and there is no notice sent to the parties within 30 days of the mailing of the initial decision, then the initial decision will automatically become a final agency decision, and there's no judicial review allowed in that circumstance per state statute. And again, this will be explained in the notice of the initial decision so that parties are aware of what will occur if no exceptions are sent into the department. Next slide, please. Thank you. So we wanted to kind of distinguish what exceptions we're talking about here, because that's a term that is used in different areas of Medicaid. So what we're talking about here are appeal exceptions, and those are just written reasons sent via mail or email explaining why a member, applicant, or the representative disagrees with the administrative law's initial decision and why the decision should be changed. However, there are other types of exceptions, one of which pertains to personal care, homemaker, and health maintenance activities exceptions. And while I'm not an expert in that area, this is just a quick summary of what that is. So there are annual service limits referred to as soft caps for personal care, homemaker, and health maintenance activities. Members with needs that may exceed the annual limits for these services may work with their case management agency to request an exception to the unit limit. That is not what we're referring to here, so we just wanted to make that distinction clear. Next slide, please. And again, Kelsey Leavitt did a great job in our initial presentation of this rule, explaining in more detail our stakeholder engagement process for this rule. But we thought in this case, in final reading, let's just keep it as a quick summary to save everyone some time. So in summary, a stakeholder survey, meetings with advocates, and a large public meeting informed the proposed policy. We want to thank all the stakeholders who gave their time and expertise to help shape this rule. It is stronger because of it. The full stakeholder engagement process is outlined in the stakeholders' comment summary and the feedback log if you would like to see additional detail. Next slide, please. Okay, statutory authority. We wanted to address this briefly. We went into more detail in the initial presentation, but just wanted to provide a quick overview. Next slide, please. So the purpose of the proposed rule is to establish a procedure for reviewing initial decisions for which no exceptions, i.e., or in other words, disagreements, have been sent into the department, rather than the full substantive review of Colorado Revised Statute 24-4-105-15. The department is granted the authority to establish this procedure under Colorado Revised Statute 25.5-1-107, subsection 1. Currently, all initial decisions receive a full substantive review. A backlog of appeals decisions, including initial decisions not disagreed with by the member or applicant or the department, is the result of our current process. Next slide, please. Okay, now I'll go into more detail exactly what changes and what does not change in the appeals process in this next section. Next slide, please. So 1 and 2, so first there's the appeal. A member applicant or the representative has 60 calendar days after the date of the notice of action letter to submit an appeal to the Office of Administrative Courts. After the appeal is submitted, a hearing is held and the Office of Administrative Courts Administrative Law Judge will issue an initial decision. Next slide, please. So under the proposed rule, there is no change to these first two stages of the process. Next slide, please. Following the hearing and the initial decision, so after the initial decision, a party may send the Department's Office of Appeals exceptions, which again are just written reasons explaining why a member applicant or the representative disagrees with the administrative law judge's initial decision and why the decision should be changed, by mail or email, asking for further review. Exceptions must be sent within 18 calendar days under the current rule. An exception can be as simple as an email to the department stating a member or applicant's disagreement with the initial decision. Moving on to the final agency decision, after reviewing the judge's initial decision, any written exceptions, and any responses from the other side, the Office of Appeals will send its final agency decision. A final agency decision will 1, confirm the initial decision, 2, overturn the initial decision, or 3, send the appeal back to the Office of Administrative Courts for another hearing. So that's the current process. Next slide, please. So under the proposed rule, the exceptions process remains the same. However, we've provided an additional 2 days for mailing. So instead of 18, there's 20 days, and that's in response to stakeholder comments for mailing delays, specifically in rural areas. We also added a 45 calendar day extension for the original due date for sending in exceptions for members or applicants who request transcripts of the initial decision. So that's what's changing under the proposed rule. For final agency decision, as I went into more detail in the infographic, rather than all final agency decisions receiving a full substantive review and separate final agency decision, under this proposed rule, only those that have exceptions sent into the department, requests for additional time, or requests for transcripts will be guaranteed to receive that full substantive review and separate final agency decision. Now, again, there's that sidetrack of.
There it is. This is Dave Plump. We're going to go ahead and restart the MSP. Certainly sorry for that interruption in your presentation, Mr. Ziegler. Would you go ahead and get us restarted?
This is Russ Ziegler. No problem at all. These things happen. So I'll just jump right back in where we were. So again, this is the part of the appeals process after the appeal has been requested. There's been a hearing and an initial decision. Now we're at the exceptions part. So as indicated before, there are some changes to the exceptions process under the proposed rule. Primarily, we're extending the time to file, or excuse me, to send in an exception to the department. It is 18 days on the current process. It's now 20 calendar days. We also added a 45 calendar day extension from the original due date for sending in exceptions for members or applicants when written transcripts are requested. And then finally, the final agency decision. So under the proposed rule, not all initial decisions will receive a full substantive review by the department and have a separate final agency decision rendered and sent to the parties. That will only occur where there are exceptions filed or transcripts are requested, or in the case where there's an administrative review where no exceptions are sent in or transcripts requested or request for additional time, the department can still elect under administrative review to do a full substantive review and issue a separate final agency decision. So we wanted to highlight those specific changes. Next slide, please. Now, this is the final bite at the apple. This is at least in the administrative appeals process. So this is the motion for reconsideration. So under the current rule, if exceptions were not sent to the department's Office of Appeals and the initial decision becomes the final agency decision, a member or applicant may still send a motion for reconsideration within 15 calendar days by explaining a good cause reason for missing the exceptions deadline. Next slide, please. Under the proposed rule, this will be clarified, and this was in direct response to stakeholder comments. First, I'd like to note that we've added 5 additional days to send in that motion for reconsideration. Just as there's more time to send in exceptions under this proposed rule, there's also more time to send in a motion for reconsideration if for some reason a applicant or member was not able to send in their exceptions. So we added a good cause definition. Good cause shall mean circumstances beyond the control of the member, including but not limited to medical emergencies or hospitalization, a member who has a disability or other medical conditions requiring additional time and or assistance, or a statement that the party did not receive the initial decision prior to the deadline for exception, which would incorporate situations where the mailing was not timely. Next slide, please. So what doesn't change in the proposed rule? So members, applicants, or their representatives will continue to have the same rights to request an appeal, to continue services and benefits during an appeal when eligible, to have a hearing in front of a judge during which they can present evidence and arguments, to receive written initial decisions after the hearing, to raise disagreements with the initial decision by sending in an exception, and to seek further review through exceptions as they do under the current process. Next slide, please. So what does this look like? The process that begins when a member, applicant, or representative sends in exceptions would not change. So, like I said before, the full substantive review, a separate final agency decision, that will continue under the proposed rule when exceptions are sent to the department. So the Office of Appeals would continue to conduct a full substantive review in those cases and issue a separate final agency decision, just as it does today. Members, applicants, or their representatives' ability to challenge an initial decision and seek further review remains unchanged, and we really wanted to make that clear. Next slide, please. So why are we proposing these changes now? Next slide. So federal law requires all applicant and member appeals be resolved within 90 days of the date the applicant or member asks for an appeal. The department is not meeting this deadline due to staffing shortages and process delays. Next slide, please. There are negative impacts from these delays. First, people who are denied Health First Colorado eligibility or benefits or are not receiving services have to wait longer to have their appeals resolved, lengthening the time they may go without needed care. Also, cases are not finalized for a long time, which can lead to increased costs related to benefits provided to people who no longer qualify for services. This impacts Health First Colorado's ability to ensure that limited state taxpayer dollars are directed to the individuals who need them most. Next slide, please. This is a snapshot of the percentage of decisions that are, well, let me just say this. In state fiscal year 2024-2025, the Office of Appeals reviewed 2,565 initial decisions where there was no exceptions sent into the department. So in other words, these are the initial decisions that no one has disagreed with. There were 2,565 of them in that state fiscal year. Of those, 7 cases had final agency decisions that changed the initial decision. 2 of those were in favor of the member or applicant. 5 of those were against the member applicant. 4 cases were remanded to the Office of Administrative Courts for a new hearing. We just wanted to provide this snapshot of the current data to show the very small percentage of cases that are actually overturned or changed or remanded by the Office of Administrative Courts for initial decisions for which no disagreement was indicated by the parties. Next slide, please. So, final reading updates. I believe it was President Hump who requested we provide an update in the final reading about emailing notices. Next slide, please. So first, I wanted to address that there's a current House Bill 26-1343 under consideration by the General Assembly, which would allow the Service of Appeals decisions to the member applicant by email rather than mail upon the documented request or consent of the member or applicant being served. Now, I checked that bill this morning and it actually passed yesterday. So this has been passed and it will be implemented in the time frame of that legislation. Next slide, please. Next slide, please. So this may be not as relevant now that legislation is passed, but we wanted to provide context about the limitations on implementing this immediately. So currently there are limited staff. There's one to implement emailing notices, and resources prevent us from immediately implementing this option as an addition to mailing decisions. However, we are investigating what system changes would be needed to convert to an email system, which, as I said, that legislation appears to be requiring now anyway. Next slide, please. By way of example, the Department of Human Services Office of Appeals estimates it would take them 2 to 3 years before they can implement an email system, and they have comparable staffing levels, no backlog, and approximately half the caseload HCPF has, the department has. Next slide, please. So that's our final presentation for this rule, but we're happy to take any additional questions. And like I said, we do have additional subject matter experts on the line that can address any number of questions you may have. Thank you.
Thank you, Mr. Ziegler. Certainly appreciate that. Again, I apologize for the disruption in the middle of your very concise presentation. Thank you for doing that. Board members, I'm looking around the room and online questions, and we're going to start with James.
Thank you, Mr. Chair. Mr. Ziegler, as always, great presentation. Thank you for that. I did have one question. For the appeals process, for people to file the appeal, it looks like the only way it can be done is in written form or via email. Is that correct? Or are there other options for making the appeal for folks that might struggle with the written formats?
Thank you for that question. This is Russ Sigler. My understanding is it does have to be in writing. However, I will ask Christine Niernes, our appeals officer, to weigh in case there's any additional modalities that a applicant or member can request send in an exception.
Christine?
Yes. Can you hear me?
Yes, ma'am.
Yeah.
Okay. Yes, this is Christine Nierens. And as far as filing appeals, members or applicants also have the ability to phone in their appeal to the Office of Administrative Courts and get an appeal started that way.
Does that answer your question?
Yeah, Mr. Chair, it does. Thank you. I appreciate that. That sets my mind at ease.
I appreciate that as well. Board members, do we have any other questions, comments? Online, I'm assuming no, unless you speak out. All right, thank you. Mr. Sykes, do we have public testimony?
This is Chris Sykes. We do. We have Katie Wallet signed up.
Fantastic.
Can you all hear me?
Yes, Katie, we certainly can. Go ahead and start your 2 minutes.
Thank you. Good morning, Chair and board members. I am Katie Wallet from the Colorado Center on Law and Policy. I am testifying once again to urge you to reject this rule, which removes the level of review of the appeals process that our elected officials in the General Assembly put into law more than 3 decades ago. When CCLP has spoken with community members and conducted Know Your Rights presentations about filing appeals, we have learned that most Medicaid members do not understand the exceptions process and very few utilize it. Even the word exceptions is confusing to people when the same word is used for other processes in the Medicaid system. Many people, upon receipt of the initial decision with its official headings and legal language coming from the administrative court, assume the judgment is final. We also know that most Medicaid recipients pursue appeals without counsel or other assistance and have heard numerous stories of administrative law judges not understanding the law, treating Medicaid members poorly, or infringing on their rights. This rule gives these same administrative law judges, which HCPF does not play a role in hiring, supervising, or firing, even more authority in determining enrollees' rights to due process. We do appreciate the addition of the language requiring the Office of Appeals Administrative Review to look into how federal and state law is applied. But we are left without understanding how they will do so simply by reading the initial decision written by the judge without considering evidentiary or other decisions made at the hearing. We don't know who will conduct that review and what training they will have or what that review will actually look like. This proposed rule would lower Office of Appeals caseloads at the expense of Medicaid members, the very people who need that secondary substantive review. Whether that is 10 or 10,000 members, they are all entitled to the protections of due process enshrined in state law. HCPF does not need to change the rule in such a fundamental way. They need to hire more judges in the Office of Appeals, reflecting their investment in safeguarding due process. This is all the more important on the eve of major changes to Medicaid because of H.R. 1. CCLP respectfully but strongly urges the board to reject this proposed rule. Thank you.
Thank you, Katie. Certainly appreciate that, your input. Mr. Sykes, do we have additional public testimony?
This is Chris Sykes. We do not.
All right. Department, would you like to respond to the public testimony? Mr. Ziegler, I see your mouth moving, but I don't see I see you also. There you go.
I am muted. I apologize. This is Russ Ziegler. I wanted to thank Katie and CCLP's input on this rule, both before and during this process. I think the first thing I would point back to is the appeals backlog that we have right now. We are not complying with federal law. And as the board has heard many times, we have an appeals backlog that's been going on for some time now and does have negative impacts for members and applicants to the program. The department looked at its statutory authority, and this is one area where we can establish a procedure that will cut back on the current appeals backlog in a way that we are looking at as the most reasonable way of doing so. So that's I will I don't know if Christina has anything additional she would like to add to that. But this is a process that we're hoping will reduce that appeals backlog so that people can get faster decisions and the department can comply with federal law.
Thank you, Russ. Certainly appreciate that. Any final comments from the board?
David Pump, this is Kelly O'Brien. Are you hearing us and can you respond?
Now we can hear you. Wait. It looks like the room left, maybe the online.
Yeah, I can't hear anything.
Yeah, it said Chris Sykes left the webinar.
Thanks everybody for your patience. Chris is working, I think, connecting back to the room, to the webinar.
No?
Hey Kelly, this is David. Can you hear us?
Hey, David, we can hear you.
Okay, so we're using my,
Okay.
it's now using this. Do you want me to plug this in?
Yeah, because that's gonna run the Sennheiser thing.
Can we move this way, Bob?
We can do whatever you need for the.
Just a second, we are going to private citizen technology.
This reminds me of that old episode of Friends when they're carrying the couch.
Dave, I see you connected, but we lost your audio.
Testing.
That's your.
We can hear you. We get a lot of reverb.
Testing. That's somebody else.
Is your volume?
I'm on mute. I'm on.
All right,
I will.
my voice. Okay, somebody has.
Chris?
sound.
This is Kelly. Can you hear me okay? Folks, just for the moment, just to clarify, I think everything on our side is good right now. We're just really waiting for the Wi-Fi issue to be resolved in Pueblo. So thank you all very much for your patience. Appreciate it.
Did anyone else?
Kelly, can you hear me?
Putting my faith in Christine.
We can hear you now.
Okay, this is Christina. We're now using my laptop for audio for the entire room. And I just want you all can hear me, okay? I'm sitting
We
at
can, we
okay.
can hear you very well. Yes. Mhm.
Okay. Can the room hear good enough? People want to sit closer because my volume is on high. He's trying to plug more things in. I don't know how I feel about that.
Okay.
No, I don't have that kind. This is a MacBook Air, so good luck. Yeah. Don't plug anything in, you're gonna ruin it. They're listening.
Don't worry, I got out.
Okay, well, they're listening too, so.
Well, while doing that, can we move forward? I mean, I
They
can
can,
hear.
Y'all can hear David?
I can hear you clearly, Christina. I can hear David only very faintly.
David, you want to come sit next to me?
I am so excited about to do this.
Love it.
Yeah, I can.
And then we can allow others to come sit here too if they want to speak and you can't hear them. We're rearranging the room now.
So are the Sennheisers able to be connected to Chris's laptop still or no longer?
I really made my.
I think that's what he's trying to plug one of those. I have USB-Cs on here, so he's trying to plug one into my laptop now.
I need to bring over my.
And David's sitting right next to me.
So just a second.
Yeah, that's fine. I'm gonna
And
mute
David, oh, excuse
another
me,
sec.
Christina.
I'll leave my audio on so we can hear you. I am gonna mute for a second. They're just all rearranging the room.
David or Chris, if your phone is giving you a good hotspot and you can use that in place of your MiFi, you should be able to get back on track without really too much change, just a change in Wi-Fi signal.
Is it easier to hear?
Go again.
It is easy to hear you, David. Yes.
Fantastic, because I am now very close and comfortable with Dr. Mulkey. And I think, my gosh, are we recording still and able to move forward?
We are recording and we are able to move forward.
Thank you, sir. I certainly appreciate that. Please, team here in this room, help me remember where are we in this process? Because I know that Russ, we had some questions. There was no public testimony.
I'm sorry, this is Chris Sykes. We had Katie Wallet.
Oh, yeah, yes,
We
yes.
had a discussion.
We're-
Christine Nearens
Yeah.
answered about.
And
JJ's
you answered.
Question about how we can.
Thank
do
you.
appeals. I think we're bordering on.
Let's do a motion. I appreciate that. For everybody to get on the same page, we're on document 2. Because we are cooking on this in this meeting. We're on document 2 and board, I am looking for a motion. Please and thank you.
This is J.P. Costello. Move the final adoption of document 2 MSB 25-19-13B provisions of the Medical Assistance Act rule concerning appeals process. Sections 8.057.9 to .11, incorporating, sorry, I'm gonna read this, that sections 8.057.9, 8.057.10, and 8.057.11, incorporating the statement basis and purpose, specific statutory authority contained in the.
Oh, I see you're saying, do we have a second?
This is James Smith.
Hey, Dave.
Did you guys call for a vote? I only heard JK.
No, we lost them again.
Ah, jeez.
And Katie Wallet, I see your comment. I'll make sure to communicate that to the board. And I'll certainly open up your mic if they need clarification. Thanks for the feedback. I appreciate it. And once again, thank you for everyone on the call today and their patience in a very difficult meeting. So I appreciate it.
Are we back on now and you can hear us again?
You are, Dave. One thing to let you know, we are not hearing anything really realistically beyond you or perhaps Dr. Mulkey.
So if you want to make a motion, you have to walk over here to my computer. Okay.
All right.
That's
Yeah,
fine.
just for the record, yeah, we heard JK make the motion and James make the second. I got that.
Okay.
Excellent.
So we need to vote.
So now we are going to clarify the vote. All in favor, say aye.
Aye.
Did you feel comfortable with that?
Yeah.
Okay. Any opposed? Any abstentions? Motion passes. Thank you. We feel good about that. Okay. Well, in the spirit of feeling good about things, we need to go back and clarify the vote on document 1. And to clarify the vote on, we're not revoting, we're just clarifying. And for that, I need Chris Sykes in a second.
Sorry, can we get a this is Rachel Entrican. Can we get a clarification on who seconded the motion for document 2?
That was James.
And I apologize, Mr. Pump, what was it that you were doing?
All right. So what we are going back to document 1, and we're not revoting, we're clarifying. And in that clarification, we're going to do a roll call vote. Mr. Sykes, and when you call that person's name, they are going to state what they already voted because we missed some votes. Does that make sense? Are we down?
This is Chris Sykes, yes.
All right. So, Mr. Sykes, will you please call the roll call? Board members then just say what you said initially. This is document 1. Mr. Sykes.
J.K. Costello. Aye.
He said aye.
Morgan Honey.
I seconded and I voted aye.
Amanda Jaslinski.
Aye.
William Kennard.
I voted no.
Kasana Littler.
Aye.
James McLaughlin.
Voted aye with a heavy heart.
Christina Mulkey.
Aye.
David Pump.
No.
3, 4, 6 to 2.
Correct. All right. And it still maintains there's no change that the vote and the vote, same thing. Whew. I feel like we are ready to move past these complications, and we're going to have Ashley and James, I'm assuming.
No Doc 3.
No Doc 3. That is absolutely right. I remember you said that. We're going to even go beyond that. We are now going to go into the initial approval process. I'm so excited because I do know this without shadow of doubt that Adam Tucker is ready to present on document 4. And I know this because I physically see him.
David, this is Kelly.
The host has a hand up.
All right, I see a hand up. You touched it.
Yes, David, I just want to convey that Katie Wallet in the Q&A conveyed that the concern here is the recording did not pick up anything of the board discussion or questions on the document 2. So I think that, I don't know what we would need to do there in terms of response, but I just want to raise that concern for you.
Thank you. Give me half a second to confer on what that means. Technically.
Are we sure? Kelly, can you tell what recorded?
That's Rachel.
So what we will record is what we hear. I have my headphone about 75. I did not hear very much of any of the questions and discussion the board was having around Doc 2 at the end.
That is a problem if we're not able to have that recorded. This is David. Yeah, I think we are going to do some office or room changes. And all of you guys on that side of the room, I need you to get comfortable with us. Adam, when you come and present, I need you to sit right there.
Would you like this table out or over?
I don't really care where that table is.
We need to move all of these together.
I feel like we are having a fun time.
I have a board member here and then.
I think we have to pick it up. Yeah.
For the record, I am exceedingly grateful for everybody moving things around. JK and James, let's move you this way. If you need Luna to pull that for you, I'm sure she's good with that.
And Dave, while you're working to rearrange the room, can you take a look at the questions coming into Q&A?
I will certainly try to look at the questions on Q&A.
Thank you, sir.
Yeah, she's correct. She says that, can we ask them to repeat the question and discussion for the record? It's not an issue of the mic. It was when the audio is completely out. Yeah.
Got it.
I think we do.
That's right. We all like each other. We can sit closer.
Oh, look at there's Q&A.
Yeah, just two.
Right.
Adam, I really do apologize. We're going to ask you to go get lunch for everybody. Is what we're going to ask you to do. That is a joke for those reading the CC.
Are we recording now?
We are recording.
We are live. Well, we're live on audio.
This is Rachel Intrican. There were 2 questions that were asked at the end of document 2, one by Mr. J.K. Costello. And one by Mr. James McLaughlin. Mr. McLaughlin asked whether or not there was another option besides mail or email to submit an appeal. And the answer to that is yes, there's another option. Individuals can phone in and ask that an appeal be filed. And I don't remember JK's question.
Retro. Yeah.
JK.
Thank you.
Yeah.
So the other question from Mr. Costello was whether or not the effect of this rule would be retroactive. The answer to that question is no.
Thank you, Rachel. Appreciate you saying that. Those were the 2 questions and the discussion and then the vote. So now we're solid. Unless I hear anything else from Denver. All right. With that, we are going to go. We are going to go into document 4. I was going to say 3 again. with Mr. Tucker. Mr. Tucker, please help us out of the situation.
Absolutely. Thank you, President and the rest of the board members. A quick question, did you guys get my slides?
Kelly, do you have Adam's slides for Doc 4?
At least not at this moment. Let me take a look real quick.
Kelly, can you just give me permission to share and I can pull them up?
You got it.
Thank you.
Hmm.
Hey, Dave, is there any chance to get Adam a little closer to the mic?
Yes, we
just speak up a little bit louder as well.
Yeah, do you want to come sit here?
Sure.
Switch me.
Yeah.
Just don't touch anything.
Well, now
Don't
you guys
touch
have to be nice to me because I'm officially part of the board.
That's way better. Thank you.
Okay, good.
Thank you, Morgan, for that. And also for record, Adam's not part of the board. But the feelings are there.
Well, I'd have to abstain, right? Because this is my rule. So
That's right.
yeah. Okay. Well, thank you, MSB board. We're really actually very excited about this. This is a set of rules that I've been working on. My name is Adam Tucker, and I work for the Office of Community Living, which is part of HCPUF, and we oversee home and community-based services. And then I am the supported employment policy advisor, and my partner in crime, who is online, Jenny Jordan, also works on supported employment for the IDD waivers. So the SLS waiver and the DD waiver is currently where we have supported employment services. I started working on this about 7 years ago. And so this is a pretty big day for me. We're pretty excited about this. And so we'd really like to just kind of hop in. So really just basically looking at what we're trying to do with this rule is we're trying to modernize the rule and improve the clarity and alignment and align with employment first policies. We're also part of that alignment is to implement an outcome-based supported employment model. And that is probably the largest change that you're going to see in these sets of rules. We're also breaking the rule down into more than 3 subsections. So the general supported employment, group supported employment, and then individual supported employment, which is the outcome-based model. We're also looking at training sections to align with the Colorado statute and also offer some alternative ways to get some revenue resources to make sure that staff are trained and can implement national best practices. And then finally, we're expanding workplace assistance to really support or continue to support people who are going to need ongoing supported employment type job coaching while they're at work. Just really quickly for just kind of an understanding of what we're talking about here. So on the DD and the SLS waiver, there's an umbrella of supported employment. Those are then broken down into individualized supported employment as well as group supported employment. The outcome-based model is going to affect the individualized supported employment aspect. Now, underneath those two, that group and that individual, we have what we call job development. Job development is that surface that really supports people in identifying the types of jobs they would be interested in, where they would be successful. And it's a really important part to utilize so that the member who gets the job, has that job, also has the ability to fade. So fading is the process of pulling back supports and really supporting the member in becoming more and more independent. And so that job development is actually a really, really important piece of this entire process. Then there is the job coaching. Job coaching is the process of somebody going and working with somebody at the work site to help identify natural supports, to help learn the job tasks, to help talk to managers, to help kind of become more and more integrated. And the key with that is, as a job coach, I'm going to work with somebody to help them do those things with the idea that I want this person to become more and more independent in this job and I can fade out. And then finally, workplace assistance. is for those members who either have a community safety concern, that could be either medical or behavioral, but as well as people who are going to just need ongoing hand-over-hand support, and that fading has kind of stopped, and it's not going to go much further. Because the way we're paying for this new model, that workplace assistance is kind of that backup for individuals who may not be able to fade to the point where they can truly be by themselves or getting support through remote sources, those different types of things. I want to first state too that we have been building this for the last 7 years with a lot of our partners around the state, and I want to thank them very much for the work that they've put in and really allowed us to build this model to both support the providers who can then support members in really achieving competitive integrated employment and employment as a social determinant of health. This is not about work requirements or anything like that. This is about community integration. This is about helping people who, most of their lives have been segregated, and work is one of the best ways to support people moving away from segregation. So those are Colorado APSE, the Alliance of Colorado, Employment First Partnership, and Kojo, who is the president, is actually in the room, the Colorado Office of Employment First, the Division of Vocational Rehabilitation, and also just all of the other providers, the family members, the members, the advocates, and everybody else that we have worked with over the years to really build this out. So what is this going to look like? So really our main goal is that this model was approved through legislative action last year in the budget and the long bill. And then the outcome-based model improves supports, leads to better employment, at the same time generates cost savings for the state. I want to really reiterate that the cost savings when we're talking about this model was an absolute accident. We did not know it was going to be cost savings, but through the efficacy and through making this more streamlined process and helping and focusing on member independence, we're actually going to see some cost savings with this, while the model itself will support providers in maintaining the revenue that they need to maintain these types of programs and be able to build them out. The outcome-based model will also use some universal tools. This really is so that training can be done better. We can make sure that national best practices are being followed. And it also really helps case managers understand and be able to monitor what's going on and if services and supports are actually being successful in supporting the member in being part of on their employment journey. The outcomes are tied to reimbursement. The outcomes are really meant to make sure that people do not stall in different parts of this. We currently have members who may be in job development for multiple years, when in actuality that should be a pretty intensive process, but it should not be a long-term process so that the member is still moving towards employment of some kind. And then we're also sequencing services. Sequencing of services actually has made us known around the entire country for the way that we implement supported employment. And that means that we can sequence with the Division of Vocational Rehabilitation and HCPUF. And what this does is this allows for members to access these services, but also have access to all the resources that Colorado has. And it allows them to move through that very, very quickly. And then this is also going to allow us better data. So that will allow us the ability not only to identify groups of people, maybe based on their support level, but also parts of the state where people may not be seeing success. That will allow us to come in and really be able to offer additional resources to help them get connected to places like the Colorado Office of Employment First, to help them get connected to the Association for People Supporting Employment First, which also has additional training and different things like that. And then also, Jenny and I love working with providers, love working directly, and really trying to make sure that the members themselves are achieving the thing that employment can do. Employment is so important for individuals to really, truly understand and have a place where they're going where their disability is not the focus. What they're good at is the focus. Because when you're working, your employer wants to use what you're good at to help them have a better business. And that's the whole goal behind really supporting people. And then all the other pieces, the pathway out of poverty, all of those different types of things. Okay, so in a nutshell, how this is going to work is that job development piece. We have two different tiers for that. So everybody's going to have a career profile. And then some folks may need a little bit deeper or deeper dive. And that's where we have the supplemental career profile. How we are paying for those is a flat rate. So it is based on the average hours that it takes job developers to walk through and to support people in being able to have a robust career profile. And then we pay a flat rate for that outcome. And then once somebody does get a job, usually through the process with DVR, they will come back to the home and community-based job coaching. And there are going to be 3 tiers of job coaching. The initial one with the highest rates lasts 1 to 90 days. The second one, extended job coaching, will last from 4 months to 18 months. And then finally with job coaching maintenance, that will last forever. The first 2 phases of job coaching, we are going, instead of the HCPF paying for every hour that the job coach is giving direct support, we're actually going to pay for every hour the member is working. This model looks at supporting a member as an investment and making sure that that person is successful is what we're trying to invest in. And so the best way to do that is to literally pay providers to get the hell out of the way when it's appropriate. And to make sure that providers have still the sustainability from the reimbursement model where they're not going to be penalized for supporting that member's independence. With the final one, it's a flat rate. It's a monthly flat rate. You kind of think about it as job coach on retainer. This is where if folks start to kind of level off where the fading can occur, this is the part of the process where somebody can choose workplace assistance and go with workplace assistance, which is back to that traditional 15-minute unit for direct service and direct support. So that's for those individuals where their independence and that fading has flattened because they need hand-over-hand support. There may be physical concerns or there may be behavioral concerns. Workplace assistance can come in and support that. And then finally, with this model, we are going to have milestones. These milestones are for providers. Again, this is about investing in members and their success in competitive integrated employment. And so we want to make sure that longevity as well as training around national best practices are incentivized, and we're doing that through milestones. So the first milestone will be when the member has worked for 12 months. The second one is when the member reaches 2 years on that job. And then finally, we have a milestone that is training with intent, or TWI. This will support providers who implement community-based training for new job coaches and new job developers, as well as making sure that those trainings are in line with national best practices, which are called ACRE domains, if anybody really wants to know. As far as stakeholder feedback on the proposed rule, we heard right away we made a mistake and we did not put the correct level of for supervisors. We were able to expand that out a little bit to also include not just an associate's degree or a bachelor's degree, but also if the supervisor is certified in those national best practices and has 4 years of experience, they will also qualify to be a supervisor. Because we work so closely with a lot of different providers, this really wasn't a shock, or members or just our stakeholders in general. This was not a huge shock for them. So a lot of the feedback that we got was really around how do we make the rules actually sound clearer and more in line or easier to follow. Okay, this is what I need to do and this is what I need to do. It also gave us the ability to understand what additional tools might need to be developed, especially for case managers. And so we have developed some tools that will help determine date spans for those different job coaching phases. It will give guidance to help predict the appropriate amount of units that the case manager should approve on the PAR. And it's also a tracking tool to identify when providers are eligible for those milestone payments. So with that, I want to thank you guys for letting me talk through that as quickly as I could, and be happy to answer any questions. Thanks so much.
Thank you, Mr. Tucker. Really appreciate your time and your presence here, talking through this really incredible piece of change for Colorado, which I'm very grateful for. I also want to acknowledge that through this very long process, you have really done a tremendous amount of stakeholder feedback and piloted parts of that process to some pretty great success.
Yes,
I understand. Super grateful for that. Couple questions to start off. Well, initial question, we're talking about timeframes because there is change that not just providers have to institute,
yes,
but case management agencies have to institute, and to an extent DVR has to institute.
Yep.
What is the time frame to get all this started?
So our goal is to have the rules pass in August. Then it will go live. We are going to start to train case managers and providers in June. And then people who currently have jobs, they're actually going to transition during their CSR. So if anybody was here during implementation of Community First Choice or CFC, it's going to do that. It's going to be that same thing. And so as somebody comes to their CSR, it'll be determined how long they've been on the job, and they'll go into that appropriate phase. But the goal really is, and we've really been trying to push out that now is the time for providers who have not been working around fading to kind of start now, so that the member is ready when that happens. We think that it is incredibly important that case managers not only know all of the ins and outs of this, but also are in communication during this transition with both providers and the member, so that everybody is on the same page about when changes are going to happen, so that it's not a surprise or a shock.
Super appreciate that. Thank you, Mr. Tucker. Can you quickly just define CSR for the good of the order?
Oh, sorry. CSR is the period of time when members work with their case managers and their providers to identify what supports and services they're going to need for the next year. I don't know what CSR actually stands for, though, so I apologize.
I know, but I appreciate you saying that. I'm kind of embarrassed because I don't know either.
I think it's continued stay review now. Yeah, thank you.
It's a continued stay review. It's super important
Yes.
in that process. So question specifically, I recognize that this change is really focused on the people that agencies such as myself have the honor of supporting. And wow, that's a wonderful change. Very grateful for that. The requirements for supervisors, the requirements are different, and I appreciate that you've recognized that. Are those requirements going to have to be in place by the end of today? Because that's August is practically the end of the day.
So at that, I would say that we do need to hear from folks right away if there is concerns around that, so we can work together on figuring out solutions around that. We've gotten a lot of feedback thus far about that. What we were able to add would cover most people who are currently in those roles and who do not have a bachelor's or associate's degree. But if there is something else we need to expand on, we're open to that now. But directly, yes, when we roll this out, the idea would be that all of that those supervisors would be in compliance with rule.
Certainly appreciate that. Just FYI, maybe we'll connect with you.
Yes.
After, because some of this training is not even available until December and winter of next year.
Okay.
Right. So I just don't know how providers would be able to get to be compliant with that process. I also just want to make a statement that there's a lot of change on our case management agencies. This is going to also impact our case management agencies who are already underwater.
Yep.
And I'm super concerned about the implementation and rollout and the impact on folks. And I would like to see the department create some sort of implementation plan that takes into account a flawed and broken system of
Yep.
people working really hard against the system.
Yes.
Thank you very much. Board, do we have any questions, comments, concerns?
Thank you,
James.
Mr. Chair, James McLaughlin here. Great presentation. I'm excited about this. I think there's some real opportunity here. Kind of piggybacking off of David's question. Is there a waiver process for providers, or will there be a waiver process for providers until that education is available and they're able to meet that standard? Can people apply for waivers, or can organizations apply for waivers?
So this is Adam Tucker. We have not, honestly, it's the first time that I've heard that there might be a gap still. So we have not gone down that, but I'm more than 90% positive we can find some way, if that's a waiver until that point, when those are open. We can also very much help and do some pushing on our side to maybe one of our state partners, like the Colorado Office of Employment First, could offer some of these trainers sooner. I know that they have some summer cohorts and different things like that, but I don't know what they're actually training on. But we may be able to also help from that standpoint as well.
Thank you. Any other questions from the board?
I have a question. This is J.K. Costello. How many providers are there that do employment services? Like I know 2 of them, and they're big and they just do employment. But do mental health centers do this? Like, give me an idea of what the scale is.
So from the IDD, from
This is Adam Tucker responding.
Sorry, Adam Tucker from the department. So we have around 200 and 250 that are enrolled as Medicaid home and community-based providers. The mental health side of this is actually a completely different conversation. It's outside of the home and community-based aspect, but Medicaid does pay for vocational services through community mental health centers, and they actually employ a nationally or internationally best practice called individual placement and supports. And it's an incredible program, and it's specifically designed for people with persistent mental health disorders.
All right, thank you.
Absolutely.
Any other board members online in the room? Mr. Kennard.
Good morning, William Kennard. Thanks for your presentation.
You're gonna have to get
I have
louder.
to talk
Mr.
louder. And I'm sorry because I'm ignorant. Multiple questions. Number one, where do you think, so you kind of have to keep track of them. Where will the cost savings come from? I'm intrigued by the relationship and potential overlap and potential redundancy and role confusion between this and what the Division of Vocational Rehab does. And I'm also developing a generic concern about how sometimes when we make these rules, we create industries. So I heard about job developers, job coaches, providers, which is employers, as I understand, right? I mean, providers confusing to me. What's a provider?
So
all those roles are confusing to me.
I would understand this, David. I understand the confusion, and I'm sure Mr. Tucker will explain that to you real quick.
I'll stop there then.
Okay. So the provider, so Medicaid pays for the service that, and through a provider, so the provider would send somebody to the place of work and work with the person at their employer. So let's say somebody works at Safeway. They work at Safeway. Safeway is their employer. The provider comes in and supports that member and teaches them the skills there. And that's a separate piece. That makes sense.
So that's not a coach or a developer.
So the provider provides the coach and the developer for the member, but the member's job is their own. That makes sense.
But PDI, for example, is an employer or a provider?
This is David. The answer to that is we kind of break the mold because we are both. PDI does both of those things. That's why it would be confusing.
Yeah. And we also have some of that is not PDI specific. Oh, sorry. This is Adam Tucker. and PDI is a bit of a different exception. I think you're also thinking about that group employment side. In those group employments, we do have providers who would start a thrift store or different things like that to support the members in kind of learning some of those vocational skills and getting some of that experience. In those situations, still the services are separate. That business has to be a standalone business, but it can be owned by the provider, and the provider can staff that, if that makes sense. And then to your other questions, so the cost savings, what's crazy right now is that because we pay for every 15-minute unit, it's only for direct support. We do not see fading in the state of Colorado right now, because it's financially hurtful to the provider to actually do that. So by being able to actually pay for providers to fade out, that efficiency adds to the ability for us to save money. And I think that in the first year, we're looking at about $1 million. And in the out years, we're looking at about $2 million of savings. And I think that just goes to show that we have a lot of committed people in the state of Colorado who currently utilize these services, but the services themselves aren't doing what they need to be doing. And through this, we're hoping that gets closer.
Thank you. Does that answer your question, Dr. Kennard? Thank you very much. Anybody, any other questions from the board, online? Mr. Sykes, I know that we have public testimony.
This is Chris Sykes. We have Vicky Ortiz.
Vicky Ortiz.
Hi, can you hear me? This is Vicky.
Hi, Vicky. This is David. Thank you for being with us. You have 2 minutes starting now.
Wonderful. Good morning, members of the board. My name is Vicky Ortiz, and I'm here today representing Colorado APSE, as Adam mentioned, the state chapter of the Association of People Supporting Employment First. As an organization, Colorado APSE is dedicated to the belief that everyone can work and that competitive integrated employment must be the first and preferred outcome for all Coloradans with disabilities. Colorado has also demonstrated this commitment through its passage of 2016 Employment First legislation. We have been proud to partner with Adam and Jenny and HCPF throughout the development of these rule amendments, and we are here today to express our strong support for the outcome-based payment model. These amendments represent a critical shift, as Adam outlined, from paying for process to paying for outcomes. Historically, our payment systems have unintentionally rewarded static long-term support rather than empowering people to pursue career growth and self-sufficiency. The outcome-based payment model will incentivize the delivery of high-quality supported employment services based on nationally recognized competencies. My apologies, I got a little one here. Our support for these rules is informed by our direct work with the service provider community. Colorado APSE has been actively providing training to service providers to prepare them for this transition. We've seen firsthand that when the roadmap rewards quality and provider competency, results follow. This model ensures providers have the tools and incentives they need to help every member secure meaningful work with fair wages and in inclusive settings. So we believe these rule changes will modernize Colorado's system, reduce barriers to independence, and advance our state's commitment to CIE. So we call upon the board to adopt these amendments, ensuring our state's financial investments reflect our shared commitment to competitive integrated employment for all who choose to pursue it. So thank you so much for your time and for your commitment to improving employment outcomes for all Coloradans.
Thank you, Vicky. Certainly appreciate your response or your words. And I'm looking to Mr. Sykes.
This is Chris Sykes. Do we have a, pardon me, Taryn Schmidt in the room or online?
Taryn is an active job coach, so she might have been called out.
All right. So if Taryn Smith comes back, we will listen in this period. But in the meantime, Mr. Sykes, who is next?
This is Chris Sykes. We have Tom Nost.
Oh, can you all hear me?
There we go. Hello, Mr. Nost. This is David, and we're happy that you're here. Your 2 minutes starts now.
Thank you. Members of the Medical Service Board, good morning. My name is Tom Knost. I am Senior Director of Programs for Continuum Colorado, which is a provider agency. I've been advocating for changes to Colorado's employment support model for 14 of my 22 years in intellectual and developmental disability services, and Continuum has been a partner with healthcare policy and financing since the first year of the pilot program that these rules were created from. The current fee-for-service model has three fundamental problems. Billable hours cover less than half the time required to achieve a good outcome, making the service financially unsustainable at scale. It incentivizes billing for support rather than fading support. It's the opposite of what leads to independence. It pays more for poor placements requiring full support than excellent placements that lead to independence. The proposed rules address all three problems. They create a sustainable business model tied to outcomes, encourage new providers to enter the market, and ensure that state dollars follow results, not billable hours. A person that is well-placed and independent in their employment is a far better outcome than a person receiving full-time support in a poorly matched job. Employment is one of the greatest social determinants of happiness for all people, and these rules help increase people receiving IDD services and accessing a level of independence that many of us take for granted. I want to specifically thank Adam Tucker and Jetty Jordan at HCPF and the members of EFAP under the leadership of Bob Lawhead, Mary Lee Boylan, and Catherine Carroll for the years of work that made the pilot in this moment possible. I close with resounding support for the proposed changes.
Thank you, sir. Certainly appreciate your words and time with us. Mr. Sykes.
This is Chris Sykes. We have Pat Chamberlain.
Looking for Pat Chamberlain.
Hello there.
Hi, Pat.
Audio all morning. Can you hear me now?
We can. Do you hear us? Oh, no.
Isn't she?
Can you hear me now?
Pat, we can hear you. Can you hear us?
Couldn't hear us after we disconnected her other account.
Correct. Yeah. Our friends in the room that have connection with Pat, are you texting her? Thank you very much.
Do what she did last time.
Yeah, we need some magic.
My name is Pat Chamberlain. I'm a mom of a 29-year-old young man with developmental disabilities and other disabilities. Initially, our family opposes the proposed changes for rules for supported employment. We appreciate the work of Mr. Tucker and others on helping people with employment, but think that these rules are well intended but not appropriate for the majority of members with IDD. These rules are also based on a pilot study which had only 30 self-directed participants with very low support needs who were already employed. The proposed model is not appropriate for those with higher support needs. These rules would provide payment for the completion of a career profile, which sounds like payment for the completion of paperwork. Payment for employment services for people with IDD should be simple. Payment should be made when a member gets a job, and payment should be made for helping them keep that job. DD and SLS members typically have an IQ under 70, and about 75% are not employed. Gaining employment should be the primary goal for members who are able to work. Many members will require employment support that will not fade over time, so fading support should not be a goal for most. According to National Core Indicators for Colorado, the 25% of people with IDD who do work in Colorado work an average of 6 to 12 hours a week because their disabilities make them unable to work full-time. Full-time employment is unfortunately not an appropriate goal for most people with IDD. Since DVR now has a wait list over a year, we would ask that these rules be tabled or removed until people with IDD and their families have more input into these rules so that money is not spent on this well-intended but misguided new set of rules. Thank you.
Please convey our gratitude for her speaking. Do we have more public testimony, Mr. Sykes?
This is Chris Sykes. We do. We have Ellen Jensby.
Ellen Jensby, are you available?
I'm here.
Wonderful.
Hi.
Ellen, thank you for being here. We hear you, and your 2 minutes starts now.
Thank you so much. My name is Ellen Jensby. I'm the Public Policy Director for Alliance. that Adam referenced earlier for purposes of this conversation. Our membership impacted our IDD providers all across the state of Colorado, many of whom provide or would like to provide supported employment supports. We also represent many case management agencies. As several of the speakers have alluded to, employment has a laundry list of benefits for people with IDD, including greater community integration and inclusion, improved safety and reduced vulnerability, better mental and physical health outcomes. I could go on. Despite these important outcomes, however, providers have struggled to maintain these supports in the existing reimbursement model. During the pilot of this program, as Tom Knost mentioned, Alliance members who participated found that it made supported employment services financially sustainable for their agencies as opposed to being a loss leader, while also allowing them to align with best practices in employment supports and create better outcomes for those they support. Given the anticipated budget savings, we see this policy as a win-win-win for Colorado, for IDD provider agencies, and for people with IDD, and hopefully for the MSB today after a difficult morning you all have had. So we strongly support its adoption. Thank you very much.
As always, Ellen, I appreciate your point of view and your information. Mr. Sykes.
This is Chris Sykes. We have Mary Hennick.
Mary Hennick.
Hello, my name is Mary Hennick. I'm a member of COAID and a retired special education teacher, as well as the parent of a 25-year-old with IDD who's on the SLS waiver and receives supported employment services. I strongly support competitive integrated employment for people with IDD, and I appreciate HCPUF's efforts to improve employment opportunities. However, I do have concerns about these changes. My son just celebrated his 4-year work anniversary, but that success did not happen quickly or easily. It took nearly 2 years of searching through multiple agencies, extensive front-end planning, and strong advocacy to prevent him from being pushed into jobs that were far below his abilities and potential. The reason he's successful is precisely because so much time and individualized support went into finding the right fit up front. So it is perplexing that the proposed model is based on cutting $618,000 annually from the job development phase. But what is truly mind-blowing is that when I ran the numbers for my son's current job coaching, it showed that less than $3,000 had been billed to date. However, under the proposed model, where providers are paid for every hour the member works for the first 18 months, a provider would have received $51,000 over those 4 years. That makes it difficult to understand how this program could result in a $2 million per year cost savings, unless the savings are coming from somewhere else. The proposed model appears heavily skewed to incent providers to work with those who require the least amount of support. And that is why I'm deeply concerned that fading supports over time may not be well suited to individuals with the highest support needs. For many individuals with IDD, supports do not simply fade away. Some people will always require ongoing coaching, cognitive prompting, behavioral supports, or other supervision in order to maintain stable employment. Workplace assistance is much more restrictive and is not a replacement for job coaching. Before moving forward, I strongly encourage the board to require a more transparent cost-benefit analysis, better outcome data supported by level, and stronger evaluation of the longer-term impacts of this proposal. Please see my written public comments. Thank you.
We appreciate your time, Mary. Thank you so much. Mr. Sykes, do we have additional?
This is Chris Sykes. We have Bryce Rafferty.
Mr. Rafferty, are you there?
I am. Can you hear me?
Yes, sir, we certainly can. Thank you for being here. Your 2 minutes starts now.
Wonderful. Good afternoon, Chair and members of the board. My name is Bryce Rafferty, and I'm here on behalf of the Colorado Cross Disability Coalition. We strongly support this rule and appreciate the thoughtful work HCPUF and the rule authors have put into supported employment framework. This rule reflects a strong regulatory posture. It aligns reimbursement with employment outcomes, supports competitive integrated employment, and recognizes that people with disabilities should have real opportunities to work in integrated settings, build independence, and participate more fully in community life. We especially appreciate that this rule builds upon the referenced pilot and is thus evidence-driven. The pilot showed promising results, including increased independence on the job and increased hours worked for participants. That matters because the current structure can unintentionally reward more service hours instead of better job matches, as you've heard, natural sports fading, and long-term employment stability. This rule moves the system in a better direction by rewarding providers for helping members succeed at work, not for billing more time. We also appreciate the department's holistic approach, clarifying individual versus group employment, improving coordination with DVR, updating case manager training, and recognizing workplace assistance for members who may need ongoing support without being excluded from employment. Those details are important because high support members must not be screened out in favor of members who are easier to serve. The CCDC encourages the department to treat this rule, in fact, as a model for future waiver and program development. The same principles, outcome-based orientation, community integration, and public data monitoring over time could help other disability populations as well, including people with behavioral health needs, brain injuries, and physical disabilities who want to work but need individualized supports. The results will increase independence, improve lifestyle, and by extension, better health and community outcomes. If this program is implemented, CCDC asks the department to continue tracking outcomes publicly, including hours worked, job retention, regional variation, and whether members are actually moving into competitive integrated employment. With that monitoring, this rule can be.
Mr. Rafferty, appreciate your time and coming to the board with your information. Thank you for being here. Mr. Sykes.
This is Chris Sykes. Gonna do a last call out for Terrence Schmidt.
Thank you very much, Mr. Sykes. Mr. Tucker, do you have a response to our community public testimony today?
Yes, absolutely. And first thing I just want to mention too is that we know this is a major change in Medicaid, and we really haven't done models like this within home community-based services in the past. And so Jenny and I on OCL all recognize that this is going to be an evolution. And so working together and making sure that that this is successful is really what we are committed to. When it comes to folks with higher support needs, right now our current model only has one reimbursement rate for individualized supported employment. Under this model, we will have 7 different levels of support for that. So we will actually have higher reimbursement rates for the members with those higher support needs. So combination with that, as well as the use of workplace assistance, we are hoping really does support as many people as possible. One of the big things we actually did learn from the pilot, and we heard this from a lot from the providers that were engaged with the pilot, was that over time, when they started to work with folks with higher support needs, this model actually allowed them more flexibility, which actually means that instead of right now, the current model is you have one job coach per one person. This is in general, this isn't across the board. If you go to PDI, you probably won't see it that way, but in general, that's how it works. What this model allows providers to do is say, okay, we have somebody who is fading. They're on that trajectory. We're fading out. Therefore, we can take that resource that's in that highly trained job coach and actually support them and move them and support some other folks who may need higher support needs. So this also creates some of that flexibility. When it comes to the amount of hours that folks are currently working, the current reimbursement model is actually one of the reasons why we continue to see low levels of hours, because right now it is based not just on when the member is available, but also when their job coach is available. So if you have a job coach who's working with multiple people, you have to take into consideration what that member's shift is to make sure that job coach is there to help them. And this really does try to allow for some of that flexibility. Again, we are going to watch this data. As Bryce mentioned, we are hoping to create a dashboard and really support in what the data we're looking at. We are required by Senate Bill 18145 to actually release this data annually at least, and we're hoping that we will be able to do that more often. Last thing that I just want to say too is that in my own personal career, I've worked with many people who are on the highest of support levels. And there has been many times where people come in and said, this person cannot work, there's no way. And through really, really thoughtful job developments, which our model is designed to support, and with the ability to support the member and be able to be there and to come and go as they're needed. I have seen folks with the highest of support needs be successful in competitive integrated employment and find that independence that they've never had before. Not saying that this model is perfect, not saying that it does not need to evolve. And my goal and my hope is to continue to work with this incredible stakeholder community that we've been able to build through this to make sure that this model not only is successful at onset, but continues to be successful as we go forward.
Thank you, Mr. Tucker. Certainly appreciate that. I just wanted to add in here that I'm exceedingly grateful for this change. Really looking forward to this. I take exception, however, to the statement that fading is the indicator of success for the person being served or the person that's employed. As we all know, everybody's different. And my fear in this process is that those with more needs will be left behind, which seems to happen with every progressive change. It happens for folks with more need. So I would really encourage you when you come back next month, because it's initial, to talk about the dashboard you were putting together, because this is a huge change in a system that is rife with people and processes that don't appreciate change. And so I would really like to see that when you come back. I think we're at the point now of asking for a motion. Dr. Kennard.
May I make a quick comment?
Oh, heck yeah.
I really appreciated Mr. Rafferty's comment about seeing this as a bigger pilot for other programs. And I think it's exciting, and I'm developing bias about when you just simply pay fee for service, you just incent, turn in the crank. And that's how so many processes, we see so many graphs of expense go through the roof. So exciting. That said, it makes me a little nervous when the industry organizations are in vocal support and the two moms are nervous. So I listen to the moms. That said, we have an opportunity here. So I will also I'm going to support you enthusiastically today, but I'm going to watch for that dashboard and what you're going to tell us next month, what you're going to show us a year from now about here's what happened at the individual level, at the provider level. So thank you for that, but with caution.
Dr. Kennard, am I assuming then that you are going to do take that initial
Thank you.
motion?
Okay, I move the initial approval of document 4 MSB 25-6-17-A, revision of Medical Assistance Act rule concerning developmental disability and supported living services, supported employment supports, and workplace assistance, sections 8.7549 and 8.7558, incorporating the statement of basis and purpose and specific statutory authority to obtain.
Thank you, Dr. Kennard. Do we have a second?
I'll second.
Thank you, JK. All in favor?
Aye.
Aye. Opposed? Abstaining? I feel as if I heard everybody do that. Rachel?
This is Rachel Entropin. I just wanted to call everyone's attention to the chat. Dr. Littler voted aye.
Perfect, thank you. I feel confident. I feel very confident. Motion passes. Thank you. Thank you, Mr. Tucker.
Thank you, guys. Thanks for being here. Absolutely.
You're welcome. Holy moly. I can't believe we're already on to document 5. I'm looking at the time. Somebody did say good afternoon. I'm like, no, it's not afternoon, but yes, it is. Let's go with our document 5. And I'm trying to see who's going to be here for that. Richard Clark, are you there?
I am.
1 second, Mr. Clark, Mr. Tucker,
I'm sorry, guys.
can you turn off your camera? That would be great.
Mr. Chair, this is Dr. Littler. I just wanted to let you know that I'm unable to continue with the meeting and must drop off.
Understood. Thank you. One second, Richard, just a second here.
Do you need me to pause audio?
Yeah.
We're going to pause audio.
Yo. Mr. Clark, we apologize for that delay. We were trying to figure out this room and this space, but we would love to hear from you in regards to document 5.
Thank you, Mr. President, members of the board. My name is Richard Clark. I'm the Complex Services and Supports Manager at the Office of Community Living. I oversee, among other things, the nursing facility benefits and policy. And I'm here today to present document 5, MSB 25-08-27-A. This is the revision to medical assistance rules concerning nursing facility reimbursement, sections 8.430 through 8.449.
Oh.
And has the slide advanced?
Oh, thank God. That was Richard.
PTSD right like it's working.
Richard, this is David. Are you having any difficulties?
I've just seen a delay on the slide, but if maybe it's Kelly driving, or maybe it's me driving. I think I should be on slide 3, reason for revision.
I have this is David. I have reason for revision.
Perfect. Like delay here. This rule is related to House Bill 23-1228 that directed healthcare policy and financing to revise nursing facility reimbursement. The goals included within this were aimed at improving access to care in nursing facilities, to improving staffing ratios. This was a COVID-19 era bill that was trying to address a severe shortage in nursing facility staffing, improving the financial sustainability and transparency, and promoting innovation and quality of care. The bill actually coincided with a number of other bills that the General Assembly had passed in 22 and 23, aimed at addressing staffing shortages that had resulted from the pandemic. I have them listed on the slide here. Senate Bill 22-226 was called Care Forward Colorado. It invested in tuition reimbursement for individuals that were entering entry-level healthcare jobs in an attempt to replenish the workforce. House Bill 23-1246 extended that and added some additional careers that were not healthcare. Senate Bill 23-261 was the Direct Care Workforce Stabilization Board. And Senate Bill 22-210 required the licensing of supplemental healthcare staffing agencies. That was essentially chasing down the names of the owners of temporary staffing agencies so that we can monitor the profit margins that were going on at that period of time. Within this project, the department targeted the largest changes that we can make, or the biggest benefits that we can make initially. This rule is the 5th rule related to the project. So partially in terms of giving everyone context here. And secondarily, I've promised Dr. Kennard I'd come back with results at multiple occasions. I want to just get the context of the rules that we've already passed. In August 2023, we passed a rule that changed the way that we calculate the acuity of individuals in nursing facilities, the medical acuity, to align with Medicare standards. We changed some of our reimbursements around behavioral health supports that was aimed at increasing access to care for individuals with serious mental illness and who need behavioral health supports within a nursing facility. In February 2024, we added a high utilizer payment that targeted our Medicaid, our highest level of Medicaid providers, people that had 85% or more Medicaid census within their facilities, as well as certain rural facilities where there's only one provider. In April 2024, we added another rule that changed our pay for performance program. These were funds targeting quality of care outcomes that are designed by the provider community, as well as removing some Medicare costs that we felt were duplicative within the cost reporting system. And in September 2024, we passed a rule that required financial transparency amongst all nursing facilities, starting in calendar year 2024 and submitted in 2025. They each submit audited financial statements to the department to review so that we can monitor essentially where the money's being used within the Medicaid system. Our goal in this was to target the highest impact issues that were easier to implement first. The rule today is kind of what's left. It's more of the detailed work. But speaking towards the results of the previous rules, this is a chart up here that outlines the increase in temporary staffing costs from 2017 through 2024. And this kind of shows the problem that we were trying to address with the bills that were listed in 2022 and 2023. We saw about a six-fold increase in temporary staffing expenses within Medicaid nursing facilities between 2017 and 2022. I'm going to pause here. Am I seeing a delay on the slide advancement? Perfect. Back one. Context to the line chart.
This is David. Richard, we've seen context and results for a hot minute now.
Perfect. Okay, I've seen some chat that's maybe delayed. So this is essentially what in 2022 we initiated some of those bills. We had reached a peak up to around $150 million that was being spent on temporary staffing. Since the implementation of the rules we had mentioned, that's been cut in half. I'm eagerly awaiting the 2025 data, but we are expecting that will continue to decline. On the next slide, this also shows the pooled staffing hours by job title. And so this is essentially an addition of the temporary staffing we saw in registered nurses, as well as certified nursing aides from 2017 through 2023 that had increased by about 400%. This not only is inefficient in terms of the cash usage within nursing facilities, but in general, best practices within nursing facilities emphasizes consistent staffing as individuals that are more familiar with the patients there are better able to serve them, and it shows better health outcomes. After the implementation of MSB 231103 and House Bill 231228 funds, we saw a substantial decrease from 2023 into 2024. On the next slide, we'd see our pay for performance dollars that was related to one of the MSB rules that was passed. Prior to that bill, we were paying a fixed day add-on for our pay for performance results that range between $1 and $4 per day. We doubled those payments in 2024 and changed the funding stream so that it'll increase incrementally going forward. And as a result, we saw a substantial increase in participation. 136 facilities was the baseline in 2023. In 2026, we saw 175 facilities submit applications. That is out of 182 that were eligible. So we're actually nearing the point where nearly every facility within the state that participates in Medicaid is now participating in the Pay for Performance program, which assigns part of the reimbursement to outcomes and quality measures. And then on the next slide, existing funds in 2023 were reshuffled to increase payments to facilities that develop behavioral health supports, including enhanced staffing and training requirements. We are seeing that the population within nursing facilities is increasingly having behavioral health needs. And in an aim to increase access to care, we doubled the funding that was attached to that as well. And we saw results again. 44 facilities participated in that program in 2023. We had 84 facilities that participated in 2026. So we've nearly doubled the facilities that offer these supports within 3 years as a result of some of the rules that we had passed related to this project. And so then going forward to the next slide, we go to today's rule. We got the most bang from our buck on the first 4 rules. Today is the rule that is related to cost reporting and the base rates that we pay nursing facilities. This is much more technical in nature. So I recognize this is a very long rule set. Essentially what we've done is gone through line by line and decided what each expense should be, how each expense should be considered on cost reporting for nursing facilities. And in general, it's really hard to explain the entirety of this algorithm, but expenses categorized towards healthcare are treated more favorably than expenses categorized as administrative or administrative in general within the rule. We had a stakeholder group that went through and essentially looked at every single job title and decided where these things should be categorized so that we could set up that model for the next number of years. On the next slide, I'll highlight here the fiscal impact of this is $0. The nursing facility rate methodology essentially sets a target average statewide minimum or statewide average per diem rate. Each facility's cost report determines that facility's share of the total funding. So in gathering this group, we essentially approached this as how are we going to calculate each facility's share while acknowledging that the statewide average per diem will remain the same. And so all changes here are essentially a reshuffling of the existing funding to achieve the outcomes that we are looking for. In general, on the next slide, these rules provide extra clarity on the classifications of certain expenses and job titles. You'll see sections where they're listed out under either the healthcare section or the administrative in general section. There were a handful of changes, though, I'd want to outline. Costs associated with transition staff. Primarily admission and discharge supports are now included as a healthcare expense. We do think that aligns with the department's goals for having additional supports for transitions of care, whether it be from the hospital to the nursing facility or from the nursing facility to the community. And making that change will allow the nursing facilities to receive a greater share of their costs included within their per diem if they hire admission and discharge support professionals. Scheduling supports and software for nursing departments are now included as healthcare expenses. This was aimed at increasing the efficiency of nursing facility staffing, as well as promoting more full-time employees by having some additional administrative supports that will allow them to switch out shifts as needed. On the next slide, we'll see a few more. Expenses related to insurance deductibles and settlements were removed from healthcare to administrative in general. What we had observed were facilities with higher deductibles and settlements were drawing an additional reimbursement at the expense of other facilities. So we have changed this to move them to the administrative in general category, where there will no longer be an advantage to having higher deductibles or settlements passed through on the Medicaid reimbursement. The savings from that are functionally paying for some of the changes that we had made, moving certain expenses to healthcare. We have created some rate modifications for facilities that offer 100% private rooms. We've seen about 5 or 6 facilities within the state that offer this to all Medicaid residents. There was no price advantage. There will now be a new tier to their administrative and general rate that gives a few extra dollars a day for the facilities that are offering that enhanced level of service. And we are revising what's called our fair rental value cap calculation. Essentially, part of the rate mechanism includes an appraised value of each facility. The old method of that appraised value contained a cap that was based on the number of rooms in a facility rather than the number of beds in a facility. Or I have that backwards, the number of beds in the facility as opposed to the number of the rooms in the facility. As a result, facilities that offered private room accommodations had a lower cap. And we've revised the cap to essentially bring the facilities that have private rooms on par with the facilities that have 2 beds per room. And so this was more of the system was disincentivizing private rooms, and we have removed that disincentivization. And then finally, nursing facilities are now subject to the same annual across the board rate adjustment as any other provider. Prior to House Bill 23-1228, there was a 3% annual growth requirement that was in state law. The bill phased that out. And so going forward, nursing facilities rates will increase and decrease at the same rate as every other provider, which is much needed flexibility given the current budgetary issues that I'm sure you're all aware with. On the final slide, I want to address some stakeholder engagement on this item. As I mentioned, a lot of this is technical in nature. It's related towards cost reporting categorizations. It's related towards updating citations that were in the older version of the regulation. We did go through about a 1-year process with a wide stakeholder group, including 2 trade associations, including representatives from all of our major nursing facility chains. That included representation from individual nursing facility chains. We were very intentional with keeping both urban and rural facilities involved with this stakeholder process. Majority of them attended every single month for approximately a year. And this group has gone through that regulation line by line. We've discussed each revision, and then the proposal was shared with the broader stakeholder community. As a result, I do think the rule that is in front of you is representative of how this has been described and will be a positive change towards the nursing facility reimbursement. With that, I turn it over to the members of the board if you have any other questions for me.
Thank you, Mr. Clark. Certainly appreciate your presentation. Board members, do we have any questions for Mr. Clark? Online, any questions? Thank you. Mr. Sykes, any public testimony?
This is Chris Sykes. We have Josh Bank signed up.
And I am assuming Josh is not in the room. So we would, it's a guess.
Can you hear me okay?
There he is. Hello, Josh. I'm David. I'm thankful that you're here to give your testimony, and your 2 minutes starts now.
Sure. So I am the Director of Finance and Reimbursement for the Colorado Healthcare Association. We represent 90+% of the skilled nursing facility beds in the state. I'm really just on to support Richard. The engagement and stakeholder process was exactly as he described. We spent over a year, sometimes painstakingly going line by line through these regulations, and then we feel that we have come to a good place with all of them. Robust discussion was had, and we fully support the pass of these regulations. Thank you.
Thank you, Josh. I certainly appreciate that. Mr. Sykes, are there other people signed up for public testimony?
This is Chris Sykes. We do not have anybody else signed up for public testimony.
Following procedure, Mr. Clark, is there any response you would like to give?
And thank you to Richard Clark, the department. Just big thank you to Josh and all the stakeholders that chugged along through this over the past year.
Thank you, sir, for your kindness. With that, I am looking for a motion from the board on document 5.
Dr. Kennard.
All right, Dr. Kennard.
Happily give that with a preface of thank you for Richard for actually coming back with data, which was really encouraging. Keep that up. With that, I move the initial approval of document 5, MSB 25-8-27-A, revision to the medical assistance rule concerning nursing facility reimbursement, sections 8.430-8.449, incorporating the statement of basis of purpose and specific statutory authority contained in the records.
Thank you. Do we have a second?
This is James. I can second that.
Thank you, sir. All in favor?
Aye.
Aye.
Thank you. Any opposed? Any abstentions? Motion passes. Thank you very much.
James, there was a comment on here that you need to speak louder if you're going to speak. They said your voice was too low. Just FYI, because they can't hear you on my speaker.
For the first time, this is David, for the first time in your life, you've heard that. Because we at the Medical Service Board are record groundbreaking people. And so appreciative of that. With that, we are going to be going to document 6. And in document 6, we are looking for Maria Klickna. Are you there?
Yes, good afternoon. I'm here.
Oh, thank you so much for bearing so long with us in this process. We
Great.
cannot wait to hear your presentation in regards to document 6. Please go.
Great. Thank you, Mr. President and members of the board. My name is Maria Klickna, and I am one of the HCBS benefit specialists with the Office of Community Living. Joining me today is Karen Stewart, HCBS benefit supervisor, to assist with answering any questions. I am here to present the proposed revision of document 6, MSB 25-08-11-A. Next slide. The Office of Community Living is proposing updates to the State General Fund Program, State Supported Living Services, or State SLS, to allow members enrolled to continue to access services of personal care, homemaker services, remote supports, and electronic monitoring. State SLS is a non-Medicaid, state-funded program serving individuals age 18 and older with intellectual and developmental disabilities who need limited supports to safely remain in their communities and are not eligible for home and community-based services or HCBS Medicaid waivers. Historically, the state SLS program has mirrored the HCBS Medicaid SLS Medicaid waiver, meaning that it offers the same suite of services available on the waiver. Program funding for the state SLS program is limited to the annual general fund appropriation by the Colorado General Assembly. Next slide. Current regulations 10 CCR 2505-10, section 8.7560, allow state SLS members receiving ongoing services or those awaiting HCBS enrollment to access the same suite of services available on the HCBS SLS waiver. However, following implementation of Community First Choice, several services transitioned from the HCBS waiver to the Medicaid state plan effective July 1 of 2025. As a result, state SLS members who are not eligible for HCBS waivers and do not meet CFC level of care criteria may lose access to critical supports, including personal care, homemaker, remote supports, and electronic monitoring. Services essential to maintaining health and safety in the community. To address this gap, the department is seeking to update rule language to explicitly authorize personal care, homemaker, remote supports, and electronic monitoring as allowable services under state SLS. Next slide. This proposed change ensures continued access to necessary supports without increasing costs to the department or impacting state revenue. State SLS operates under a fixed annual general fund allocation, and implementation of this role will not change the total allocation or how current funding is utilized. The proposed role updates were shared with stakeholders, particularly case management agencies. Stakeholder feedback focused on clarifying allowable state SLS services, access when waiver services are unavailable, service limitations, including exclusion of consumer-directed services CDOS and IHSS, and monitoring and reassessment requirements. In response, revisions were made to clarify consumer-directed service exclusions, reassessment expectations, and monitoring standards, including allowing quarterly contact based on member preference. The department believes these revisions are necessary to ensure continuity of services and to support members in maintaining independence and safety in their communities. Thank you for your time and consideration. We're happy to answer any questions.
Thank you so much. Board, do we have any questions for Maria in this?
I have a question.
Fantastic.
I heard you say SLS is a non-Medicaid program.
This program that I'm presenting on today is called it's a state general fund program. It's not Medicaid, and the name is similar. It is the name is state supported living services, or state SLS. So it's a mirrored program to the waiver SLS.
Okay.
Does that make sense?
J.K. Costello. So it's overseen by the department, and that's why we're hearing this rule?
Correct. Yes. Despite it being a non-Medicaid program, we do oversee it, and it's funded solely by state general funds.
Other question. Two questions. What's the occasion on which somebody would be enrolled in this program but ineligible for Community First Choice?
Yeah, that's a good question. This is Maria Klickner from the department. A lot of these folks are really, they have an IDD, but they're really high functioning. So they might not meet that level of care that's required to access CFC services, but they still need supports to live independently in the community.
Okay.
Karen, do you have anything to add? Did I capture everything there?
Yeah, I think I would just add that part of the screening requirements for case management agencies when they're working with these individuals is to identify if eligibility has been considered for waiver or CFC first before enrolling into this program. So that's always built into that before enrolling.
Thank you. We have one more question.
One more question. This is J.K. Costello. It says this is revenue neutral, and now I believe I understand that's because it's an annual allocation, right? Not an entitlement.
Yes, that's correct. This is Maria Klickner from the department. Yes, that's correct.
Thank you.
And thank you. Any other questions from the board in the room or online? Mr. Sykes, public testimony.
This is Chris Sykes. We do not have anybody signed up for public testimony.
So this is David. I have to admit, I don't know what to do next if there's nobody to talk, but I actually do. I am looking for a motion on document 6, please.
This is Christina. I can do it since I'm sitting next to the computer also.
Thank you.
No audio issues for me. I move the initial approval of document 6, MSB 25-08-11-A, revision to the Medical Assistance Act rule concerning state-funded supported living services, state SLS program, section 8.7560, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Mulkey. Do we have a second?
This is James McLaughlin. I will second that.
Thank you, James. Do we all in favor?
Aye.
Anybody against this motion? I lost the words with Mr. Sykes. Any abstention? Thank you. Motion passes. I hear myself in stereo. Thank you, Mr. Sykes. I don't know what you're doing, but we are moving to document number 7. And Cassandra Keller, who I think has been waiting patiently this entire time.
Yes, thank you, Mr. President. I am back. Cassandra Keller, oversee our community options benefits section. Today, I am bringing forth regulations to talk about the medical assistance rule concerning medication administration. Next slide, please. So the purpose of this rule is to clarify and expand authority for trained, unlicensed provider agency staff, excuse me, to administer auto-injectable and pen injector medications within the home and community-based services developmental disability residential habilitation setting. So within those DD residential settings. This applies specifically to the DD waiver and allows provider agencies to those provider agencies to administer those specific medication type of injections. So it establishes consistent statewide expectations for written medical orders, specialized device-specific training, and ongoing license oversight and documentation and record keeping. Next slide, please. So the reason this rule is necessary is that current regulations do not clearly authorize unlicensed direct support staff to administer auto injectors. This ambiguity has led to inconsistent practices across provider agencies, potential delays in emergency response, an over-reliance on nursing staff for time-sensitive but routine interventions, and members who cannot self-administer or rely on timely access to life-saving medication. So really, this rule is bringing safety, clarity, and access improvement. So these unlicensed direct support staff who do not have, they do not work for an agency that's a Class A or Class B licensed through the home health department. They instead work for these provider agencies and are not QMAP'd or qualified medication administration personnel. They are direct support staff providing support to these members in these residential settings, and this allows them to provide injections like GLP-1s, maybe an EpiPen, things like that. Next slide. So what this rule does is it defines auto-injector and pen injector. So this is like things like epinephrine, insulin pens, glucagon. It allows those unlicensed staff to administer these medications when there's a written order from a licensed practitioner. Staff complete specialized training provided by licensed professionals. Ongoing oversight and competency validation are documented, and agencies maintain required documentation and policies. What this does is it preserves existing nursing delegation authority under Colorado regulations, and we're really carving them out. And so they are unlicensed, so there's not going to be a CNA, they're not going to be a QMAP on these individuals who are trained to be able to provide these type of medications. Next slide. So those who are impacted are those members receiving HCBS DD residential habilitation services. The others impacted are provider agencies and direct support professionals, licensed medical professionals who are overseeing these medication orders, and then those members who rely on these auto-injectable medications. They are the primary beneficiaries. Next slide. We have gotten strong support for this rule clarification, mainly from our provider agencies, from the health department. The stakeholders emphasize the need for clear delineation of roles between provider agencies, staff, and nurses, clear expectations for training and competency validation, an alignment with CDPHE rules and requirements. And there was no significant opposition or no opposition really raised for these rules. So we're refining the language to ensure clarity, safety, and practical implementation for these specific members within this specific residential setting. Next slide. All right. With that, I would ask for some questions. I know that this gets a little difficult when we're talking about nursing services, sometimes or medication administration that can be seen as skilled service, and having unlicensed individuals do that. But we do a similar thing with gastrostomy care, so G-tube, J-tube feedings. We have unlicensed but trained individuals able to provide this service to these DD waiver members. And so we're following a similar practice under medication administration for these auto-injectable meds.
Thank you, Cassandra. Board, do we have any questions? Okay, let's be loud.
Yeah,
James.
this James McLaughlin here. These medications we're talking about, these are the same medications that a family member would assist any person with if they were in their own home, correct?
That is correct. This is Cassandra. That is correct.
Did that answer your question?
Yeah,
Well,
it
I
does.
think it answered my question that you asked. Thank you very much. Anybody else on the board questions?
I had a quick question, JK Costello. I saw 3 medications listed in the document and also 2 routes of administration. But what I heard you say is it could be any medication as long as it's a pen or auto-injector. Is that right?
This is Cassandra. That is correct. Those were just examples. Yes.
Thank you very much. James?
James McLaughlin, and that brings up another question for you. What about like intranasal naloxone? Is that something that they're required to have some additional, or is that something they're already allowed to do?
Let's let Cassandra answer real quick, and then we'll go to JK.
This is Cassandra. That's an excellent question. And so I don't know is the answer. So these residential providers, as you heard, their parents, their host home providers, they don't need to be QMAP trained. They also don't need to be CNAs. I don't know what the qualifications are to give naloxone, but we're just giving them that authority so they don't have to have an RN come in and provide those injections that an unlicensed but a trained individual can provide that auto injection. But I don't know where naloxone falls under that.
Thank you very much. Does that answer your question?
Not
really.
Probably not.
I'm gonna recognize JK Costello.
This is JK Costello. Anybody who's trained in naloxone, anybody who gets a naloxone kit ideally should be trained in the very simple process of administering it. And so if they were in possession of naloxone, ostensibly, they would have been trained in that process. So they'd be covered in. There's also broad immunity for naloxone administration for virtually anyone.
I was just wondering specifically.
James is saying?
Yeah, James McLaughlin. I was just wondering specifically in this section, since there has to be specialized rules to administer these other medications. I do know that you're right, there's a state waiver, but does that apply to facilities? And would this fall under facilities rules?
That's a great question. Any response on that, Cassandra?
And this is Cassandra. No, I'd have to take that back. I mean, these are not facility licensed, so they don't have any licensing. They follow under, they have to adhere by medication administration regulations with the health department, but we have a weird carve out in that HCPF kind of set some of the regulations. And so potentially we could talk to the health department about adding naloxone. But so I can't answer that off the cuff, but we could look at adding that.
Mr. McLaughlin, do you want us to bring that back?
Yeah, this is James McLaughlin. I think I tend to agree with JK that it's probably covered under the current state waiver under the state medical director. But would you look into that more and get back to us on that when you bring it back next time?
Of course.
Thank you so much.
Thank you. Any other questions around the board? Or online? Mr. Sykes? Public testimony?
This is Chris Sykes. We have Ellen Jensby.
Fantastic. Ellen Jensby, we're looking for you.
I'm here.
Fantastic. Thank you for being here, coming back, and you have your 2 minutes starting now.
All right, great. So this important rule ensures the continuation of longstanding practice that people with IDD can receive needed injectable medications from trusted and trained personnel who are familiar to them. Without this clarification, there was a risk that this practice would be interrupted and that provider agencies would have to send nurses to provide medications needed daily or even multiple times a day, which would not have been financially feasible. And that would have put community-based placements at risk for people with IDD. So we very much appreciate the department's work to correct this issue and incorporate the expertise of disability nursing professionals into the rule. We support its adoption. And just to try to help answer the question that arose, I was phoning a friend as I was listening and I was assured that naloxone is within the scope of a qualified medical administration personnel or QMAP. So I don't believe that is an issue with respect to this rule change, if that helps. Thank you.
Thank you, Ellen. Certainly appreciate that. Mr. Sykes, do we have other community or public testimony?
This is Chris Sykes. We do not.
All right, thank you. I just wanted to clarify also, Cassandra, that host home providers who do have people that require meds are QMAP'd, because that would be a requirement as most QMAP. And actually, I feel best practice, direct support professionals would also be QMAP'd as best practice and retrained annually CPDI. Thank you very much. With that, I will ask for a motion on document 7.
This is James McLaughlin. I can take that one.
Thank you.
I move the initial approval of document 7 MSB 2511-05-A revision to the Medical Assistance Act rule concerning medication administration, section 8.7414, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you. Do we have a second?
This is Amanda, I second.
Thank you, Amanda. All in favor?
Aye.
Aye.
Thank you. Any opposed? Abstaining? Motion passes. Thank you very much. Wow, I just feel like now we are cooking. Darn, I shouldn't have said that out loud. Because we are going to move to document 8. And for that, we are looking for Madeline Quattaro. Is that how you say your name?
Portaro, yes.
Gosh darn, that's awesome. Please talk to us about document 8.
All right. Good afternoon, Mr. Chair and members of the board. My name is Maddie Portaro. I am a policy advisor within the Office of Community Living. I'm here today to present MSB 25-9-17-A, which includes revisions to the Medical Assistance Act rule concerning Children's Home and Community-Based Services waiver, community first choice, and extraordinary cleaning. I want to just start and be very clear up front that this rule change is not connected to the Medicaid sustainability initiatives. These updates are largely technical in nature and are intended to align regulation with operational practice, clarify existing regulation to align with policy guidance, and improve the overall structure and readability of the rules. Next slide, please. So on July 1st, 2025, we launched Community First Choice, the Children's with Complex Health Needs waiver, and a new benefit called Extraordinary Cleaning. Between July 1st, 2025 and June 30th, 2026, members have been transitioning to these new programs/benefits. When we launched this program, we knew we'd need to clean up regulation after the transition year. So at a high level, this rule revision does 2 things. First, it provides clarification where operational guidance already exists, but is not clearly reflected in rule. Second, it makes technical edits to improve flow, consistency, and readability of regulations. Importantly, this rule is technical in nature and does not introduce new policy or have a fiscal impact. Next slide, please. All right, so first I'll start with the updates related to the Children with Complex Health Needs waiver, or the CWCHN waiver. As of July 1, 2025, as mentioned, the Children with Life-Limiting Illness waiver was renamed the Children with Complex Health Needs waiver. That waiver then merged with the Children's Home and Community-Based Services waiver, or the CHCBS waiver. So we have CLLI, CWCHN, CHCBS. Between July 1 of 2025 and June 30th of 2026, members from the CHCBS waiver have been transitioning to the CWCHN waiver, the new waiver. This follows the transition plan found in our waiver amendments with CMS. Come June 30th, 2026, there will be no members on the CHCBS waiver, as they will all have transitioned to the CWCHN waiver, and the CHCBS waiver will be terminated through CMS effective July 1, 2026. Therefore, this rule is removing all references to the CHCBS waiver and renaming some references from the CLLI waiver and changing those to CWCHN that we missed the first time around. So these updates are purely technical. Next slide, please. So next, I will highlight the updates that we're making to the extraordinary cleaning benefit. Currently, our regulation does not clearly specify whether family members or legally responsible persons can provide this service, and this is probably one of our most frequently asked questions about this benefit. Operationally, the department has allowed legally responsible persons and family members to provide extraordinary cleaning if they are employed by an enrolled agency. This rule formalizes that practice by clarifying that family members and LRPs may provide the service under certain conditions, outlining the requirements for these providers, and confirming that the service may be delivered through organized healthcare delivery systems, or OHCDS. These changes improve transparency and align regulation with existing operations. Next slide, please. Next are the changes to home delivered meals. The primary changes here are structural. It looks like there's a lot of changes, but it's a lot of moving stuff around. So currently, the eligibility criteria is in the inclusions section of the regulation. We're moving it to the eligibility section as that felt more appropriate. Then the language throughout this section has been revised and put into plain language. And finally, references are being updated from waiver-based language that we missed in the rule draft to launch CFC to reflect that this is now a CFC service. Next slide, please. Next are updates to in-home support services, or IHSS. This rule clarifies requirements related to the physician attestation of member capacity form. So currently this form is used to determine whether a member needs an authorized representative. Members under age 18 are automatically required to have an authorized representative. Therefore, operationally, we do not require members under the age of 18 to have a physician attestation of member capacity form because this is duplicative. So we've clarified this policy to stakeholders. Again, another one of the those frequently asked questions. So we've clarified this policy when we implemented CFC in July, and we are updating regulation to ensure that it's clear. Next slide, please. Next is transition setup coordination. So existing regulation includes transition setup expenses and transition coordination / coordinators. So transition setup expenses provide a one-time reimbursement of costs needed to set up a basic household when a member transitions from an institutional setting to the community. Reimbursable expenses may include household furnishings, pantry setup, and security deposits required to obtain a lease or establish basic utilities. Transition coordination is a separate expense that reimburses the coordinator for time spent acquiring necessary household goods, working with the member to obtain a lease agreement, and coordinating with a cleaning or pest eradication company to ensure the home is safe to inhabit. So this rule clarifies that and also reorganizes the inclusion and exclusion language for better flow and clarity, just a lot of moving things around. And then we've also included that we've added explicit examples that are excluded, which are streaming services and gift cards. So overall, these changes to transition setup, the transition setup section of regulation, make the benefit easier to understand, but they do not implement new policy or have fiscal changes to the benefit itself. Next slide, please. All right, so the last change is related to the CFC medical documentation requirements. So the department's approved state plan amendment for Community First Choice CFC requires a professional medical information page, or a PMIP. A PMIP is and has been required for HCBS waiver enrollment. The same PMIP can and will be used for HCBS waiver enrollment. HCBS waiver plus CFC enrollment and CFC only enrollment. Operationally, we require a PMIP for CFC only members. However, this is not explicitly stated in regulation. This requirement makes the entire level of care process more uniform for all members, and in some cases makes the transition between programs easier. So this revision clarifies the requirement. And next slide. So stakeholder engagement, these rule changes were informed by stakeholder feedback. Since the implementation of CFC on July 1, 2025, we've heard from case managers, provider agencies, and advocates about gray areas in rule compared to operational practice. That's where the majority of these changes originated. The department presented updates during the CFC Council meeting in March of 2026, where stakeholders requested additional clarification in several areas. Based on that feedback, we made revisions to improve clarity and usability of the regulation. And next slide, please. So in summary, again, this rulemaking aligns regulation with current federal and program requirements, clarifies existing policy and operational practices, and improves the clarity and organization of the rules. And I want to reiterate that there is no fiscal impact and no new policy being introduced. Thank you for your time and consideration. I respectfully ask the board to adopt MSB 2509-17-A, and I'm happy to take any questions you may have.
Madeline, it is incredibly encouraging and life-giving to have just a technical cleanup discussion today. Thank you so much. Board, do we have any questions? Yes, ma'am.
This is Christina Mulkey, just more of a comment than a question, but that physician attestation form that you were talking about for the member capacity, you should consider changing the title off of physician, because I'm a nurse practitioner and I sign those all the time.
Very good point.
Since you're cleaning things up.
There you go.
This is Maddie with the department. I'm happy to take that back. Thank you for that feedback.
Yeah, that'd be great. Thank you.
This is David. That's fantastic.
Thank you. I just had to.
Any other questions on the board? Online? Mr. Sykes?
This is Chris Sykes. We have Brittany Tarango Guzman.
Ooh, I love that. Brittany, are you available? Going once and twice. Oh, seeing somebody. Brittany, are you there? Uh-oh, we just went on mute. Not you. Brittany went on mute. Brittany, I see your picture. I see that you're there. Can you unmute yourself? We really want to hear what you have to say. All right, Brittany, I'm sorry that I see you and I see that you're on mute and we're not able to make that connection with you. I would really love to hear what you have to say. Please send an email to Chris Sykes. Any other community public testimony is the words I'm looking for. Mr. Sykes.
This is Chris Sykes. We do not have anybody else signed up for public testimony on this.
With that, I am looking for a motion on document 8.
I'll move.
Thank you.
This is J.K. Costello. Move the initial approval of document 08, MSB 25-09-17-A, revision to Medical Assistance Act rule concerning children's home and community-based services, community first choice, and extraordinary cleaning, sections 8.400, 8.7101, 8.7200, and 8.7500, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. Do we have a second?
This is James McLaughlin. I will second that one.
Thank you. All in favor?
Aye.
And aye. Anybody? Go ahead, say that again. Was that an aye?
That was an aye, sorry.
No, thank you very much. Any opposition? Abstention? Motion passes. Thank you very much. We did have a request for a bio break. I'm gonna see, we have one more. Do we need to wait? Because we can do that. I mean, only,
I really could use to go.
all right, we
5
are
minutes.
taking a 5-minute
5
bio break. Thank you very much.
5 minutes. All right, you're on.
And we are back. I want to make sure that I see Cassandra, they're all ready and ready to go. Cassandra, we are loving to hear your document 9, please.
All right, thank you, Mr. President, members of the board. Good afternoon. Back again for the third and last time today. I am bringing forward to you a regulation that repeals the adaptive therapeutic equine activities benefit within the home and community-based services, section 8.752.4. Next slide, please. So what we are doing with this revision is deleting this entire section of the rule. We are removing this as a covered home and community-based service waiver benefit. This service was authorized but never fully implemented due to system challenges, so there has been no utilization. This aligns with benefit structure and with our sustainability priorities. It also reduces administrative complexity. And the plan is for this revision to be effective July 1st of 2026. So this rule is removing adaptive therapeutic equine activities from all of the HCBS waivers. That is inclusive of the Children's Extensive Support, the CES waiver, the Children's Habilitation Residential Program, CHIRP, and then the Supported Living Services waiver. Again, even though this was a rule, the service was never implemented after hippotherapy was removed from the waivers a while ago because of state legislation. And so we modified this benefit to be adaptive therapeutic equine activities, and that never actually got off the ground. Next slide, please. This spring, we have submitted changes to the Centers for Medicare and Medicaid Services for our waiver amendment process, and we've received authority from the Joint Budget Committee to have the service removed from the waiver, or from the waiver. So we've gotten approval from the budgetarily, and we are seeking approval from our federal partners. That's in process. Next slide, please. Just want to make sure folks are aware of current process versus proposed. So members will continue to have access to a range of therapeutic services, including occupational therapy, physical therapy, and speech therapy under the state plan, as well as music, movement, and expressive therapies within the HCBS waivers. More broadly, these targeted changes help avoid deeper across-the-board reductions and support a sustainable long-term system of services and supports. We've conducted extensive outreach, including stakeholder webinars following the governor budget release, engagement with case management agencies, and public comment period in February to outreach advocacy organizations. We've received some comments on this rule, and unfortunately, because this is a repeal, we couldn't incorporate any of those changes. Next slide, please. Equine-related services in Medicaid encompass two distinct offerings with different purposes and authorities. So hippotherapy, a covered benefit under the Medicaid state plan, is a clinical therapy modality in which licensed physical, occupational, or speech therapists use equine movement as part of a treatment. Hippotherapy is not within the scope of this rule change, so I want that to be very clear. In contrast, adaptive therapeutic equine activities, often referred to as therapeutic riding, was intended to be provided through the HCBS waivers as a habilitative service focused on skill development and is delivered by certified equine specialists. These services differ across several key dimensions: service type, so clinical therapy versus habilitative activity, provider qualifications, licensed clinicians versus certified specialists, and the governing authority, so state plan versus HCBS waiver, and the removal process. So it would take legislative action to remove the benefit from state plan versus an administrative change through our waiver process. As such, they're not interchangeable and follow distinct policy and operational pathways. Next slide, please. In summary, this rule removes a non-implemented HCBS waiver benefit, reduces administrative complexity, and supports Medicaid sustainability and compliance, and maintains access to other clinically appropriate services. And I respectfully request the board's approval and happy to take any questions.
Thank you, Cassandra. Super appreciate that. Although it makes me sad. Do we have any questions from the board?
James McLaughlin, just a quick comment.
Go ahead, James.
Yeah, I think this is one of the first rules that I remember approving. So This one's particularly rough for me. I'm very sad, but it sounds like we haven't been able to implement it anyway, so. Thank you guys for trying, and I understand under tight budgetary times, we have to make really, really tough decisions sometimes.
Thank you, sir. Any other questions? Full board, online? Mr. Sykes, any personal, I don't want personal testimony. Any public testimony?
This is Chris Sykes. We do not have anybody signed up for testimony on this rule.
Is that, I would like to entertain a motion on document 9.
I can do it. Christina. I move the initial approval of document 9, MSB 25-10-22-C, repeal to the medical assistance rule concerning adaptive therapeutic equine activities, section 8.7524, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. Do we have a second?
This is James McLaughlin. I can second that one.
Thank you. All in favor?
Aye.
Aye.
Any opposed? Abstentions? Motion passes. Thank you so very much. Thank you for your time today, Cassandra. Board, as I'm looking around and working through the notes from these last, the work that we have done so far, I would recommend document number 4 to come back. Too big, too changing. It would have to come back not in consent. And I'm also thinking it's super important. I would like to see on document 8 a cleanup on that particular form, because that's a big deal for all of us. And besides those, are there any other documents you would like not to be on consent next month? All right. So I like those not to be on consent next month. We don't need a motion for that, but we do need our closing motion.
And this is Chris Sykes. Just to be clear, it's docs 5, 6, 7, and 9. Right? Not 4, too big.
Correct. I had to go back.
You wanted that changed.
Correct. I had to go and actually look the opposite way. Yes. Thank you for confusing me right before we eat. I'm starving.
I can do the closing also.
And maybe getting a little bit hangry. Are you good? Are you gonna close? All right.
I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Thank you. All in favor?
Aye.
I don't even think we need to do that.
That one doesn't get.
That doesn't even need that.
That's the fucking rules.
But I don't want to talk rules. What I really want to do is I want to get into open forum and public comments. And I would like to invite Phoebe to the table, who, for the record, has sat patiently and so supportive.
And dog sat.
And dog sat.
I mean.
You have to sit here so we can hear you. We are limited to the MacBook Air.
I understand. I understand.
We can hear you.
Yes.
A.
Excellent.
And 2, you have 2 minutes now.
Great. Well, my name is Phoebe Blessing. I'm here on behalf of the Colorado Hospital Association. I know obviously document 3 was pulled from the agenda, but I just wanted to express sincere gratitude both to the department and to the board for the time and thoughtfulness that you have put into this issue. I know that it has been complex with many different perspectives, but we truly appreciate the engagement throughout this process. We are also grateful for the opportunity that this created to let us talk a bit more about the 340B program and provide information on how it promotes access to care and helps patients. So we look forward to continuing to do that, and just wanted to say thank you to all of you.
Well, we receive your gratitude and return it back to you. You still have 1:10, but you do not have to use it.
A long day. That's all I gotta say.
Thank you. Appreciate you being here. Mr. Sykes, is there anybody else signed up for public testimony in our open forum?
We do have people signed up for public testimony. I can call out their names. Last I checked, unfortunately, we did not have anybody online, but let's see. Tara Trujillo. You out there.
She's not in the room.
That we can confirm.
All right. Who's next, Mr. Sykes?
Bridget Danadara. Probably said that wrong. I apologize, Bridget.
Well, A+ on your effort.
Next, we have Betty Lehman, who spoke earlier and probably got frustrated.
Well, I don't see that she's here either.
Victoria Moole. Now, I will get her name correct one time.
We will appreciate that. I'm not thinking anybody else is there, sir. Is there any other names?
That just Miss Phoebe Blessing.
Well, thank you for being here, Miss
Thank
Phoebe.
Would that take up to 110?
I don't know. I stopped counting. With that, I adjourned the Medical Service Board for this month, whatever month we're in.